we need to be giving the patients the proper home exercises, the proper rehabilitation, both in the clinic and at home. So it is estimated that 95% of accurate diagnosis can be done just if you ask the right questions. Lab tests, imaging, all are just more confirmational as to what you are asking and thinking is the accurate diagnosis. So we need to know the right questions to ask so we can become efficient at how to then move into assessing the patient. For instance, this is one case that I had. This guy was a basketball player, very athletic, and there was no trauma, there was no onset, there was nothing that happened to really stand out. He just woke up one morning and started having severe pain. And almost within 1, 2 days, he was completely bedridden in pain. If the guy moved, he was in severe pain. He went to numerous hospitals, saw many doctors, had multiple tests. Nobody could figure out what was wrong with him. So if you had this guy walking into your clinic, very athletic, severe pain, what would you do with him? Right? How would you assess that patient? Well, it started out that I just asked him some questions. Nothing stood out in asking the standard questions. So then I went in and I started assessing him. Well, when I assessed him, nothing really stood out in the assessment. So then I said, okay, wait a minute, we need to stand back up. Okay, let me ask you a few more questions. And so I said, forget this particular condition. I said, are there any other medical conditions you have at all that have nothing to do with what you're currently complaining about? 5 years ago, he had a kidney stone that a doctor had put him on a diuretic. Well, it turned out that he was still on the diuretic 5 years later. So I asked him, I said, are you severely dehydrated? Do you drink a lot of water? Oh, yeah, I drink at least 10 to 12 cups of coffee a day. Drink no water. Caffeine is a sympathetic stimulant. It's a diuretic. So the underlying diagnosis was that he was severely dehydrated. Muscles will spasm and cramp and can be quite painful. So all I did is had him drink a lot of water and drink a quarter Gatorade, and he came back 2 days later completely pain-free, able to move, no problem whatsoever. All because we asked the right questions. So before we jump into treating, we need to know the right questions and proper assessment. So if in our assessment we don't see what we expect, then you need to take a step back and figure out. So we need to listen carefully to the answers that patients give us. When we ask the right questions, listen to the right answers carefully, we can start ruling in and ruling out different diagnoses. So I want to use another patient right here. So I'm going to point some things out, and we're going to look at a video of this, but you're going to see most people that are using walkers or canes are going to be using them in the problem side. So I'm going to point out some things here. Watch the left hip. Look how he shifts. Excuse me? Okay, watch how he shifts his weight laterally, side to side. When you are moving forward, you should not be shifting weight laterally because it's going to put additional stress and strain on the hip stabilizers, gluteus medius, TFL, the hip joint, and how he loads the left side. Also pay attention to his ankle, right? So let's see what happens. So he was complaining about severe right hip pain. And so what's the problem here? There's a lot of problems. We cannot just look at one of them. We need to address one of the big ones is if you notice his right ankle, there's almost no plantar dorsiflexion of that ankle. He's walking improperly. So we worked a lot on training and retraining the gait and therapy. This was mainly there for the observational skills. So how many things would you be able to pick up in watching that patient walk? This is a classic example of the kinetic integration technique in action. This patient, very wealthy, went around the world. Fortunately, he had enough money. He could go to the best hospitals around the world. Spent 3 years going to Mayo Clinic, Cleveland Clinic. He went to almost any and every doctor, hospital that could potentially help him. Finally, a doctor in London diagnosed him with a pre-existing progressive degenerative brain disease. And I met his wife, and when I asked her a few questions, some of the answers did not make sense to me. And so I said, well, the only way I'm going to be able to assess them is if I saw him face to face. And they literally flew me to him and him to me. And we met in Singapore where I assessed him. And we made such a significant change that he flew in for a month of intensive treatment. Here you see me assessing the soft tissue. So in the kinetic integration technique, we are assessing not only the spine and the joints, but we're also evaluating the soft tissue. And here you see me assessing the fascia. So over the last 5, 10 years, a lot of research has come out about the effect and the function of fascia. Before, we really didn't really pay that much attention to it, but the fascia really plays an important role in stability, function, and dysfunction, especially in chronic conditions. When you've got these chronic musculoskeletal conditions over time, you start seeing significant fascial changes, and the techniques used to treat fascia are a lot different than you'd use to treat a joint or muscle. So it took a lot of evaluation into figuring out what the heck was wrong with this guy because he had significant lower back issues, as you could see from the way he was walking. Here I'm mobilizing the spine, trying to improve the neurological function. It turned out that what ended up happening is in the history taking, it turned out that 2, 3 years prior to this, um, he can see, but he cannot react. He sees doors. He could see my hand, but he could not react. As you could see, he could not track and follow my fingers. He literally fractured his jaw into a wall, into a closed door. He could see the door, but he was walking to it and he could not stop himself and crashed and broke his jaw. Turned out he did it again previously 20 years ago, and that was a pre-existing condition. As I said, I'm a trauma specialist, so I'm really big at pulling out trauma. He had a very bad motorcycle accident in which he had fractured his face and his jaw, and it was left untreated for many years. And so we start seeing some changes. He's starting to able to track better in the eyes, and he started being able to respond better and faster. Um, so without any assistance, he would literally just fall on his face. If he started walking, he would not stop until he hit something or fell on the floor. So he had to have somebody with him 24/7. And within a fairly short period of time, we were able to have him walk, stop, and actually turn around, and walk back in the other direction without any assistance. You can see how his reflexes are much faster. You'll notice I'm changing the direction, so that he needs to be able to see and respond to visual input, and the reactions are much quicker. So yes, he had some brain damage, and this is why he went undiagnosed for so long, is because they're looking for one cause. People rarely have one cause, one problem. Most of the time, if you're over the age of 40, you're going to have numerous problems that need to be addressed. So technology is a tool, not a solution. Okay? MRIs, X-rays, whatever kind of lab work, they do not tell you the root cause of pain or dysfunction. They only tell you that there's abnormalities. And I get into this debate a lot with practitioners that, oh, it's the herniated disc. And I'm telling you, no, it is not. Up to 90% of people with disc herniations on MRI have no pain or symptoms. So yes, you will see disc herniations. I'm not saying that we don't have disc herniations or that they need to be dealt with, but those are rarely the true pain generators. So if you're dealing with patients with a lot of pain, you need to be looking beyond that disc herniations. Another thing, discs are not meant to be shock absorber. This is a massive, massive problem in rehabilitation and fitness and in rehabilitation that We tend to think that the discs are the shock absorbers. They are not. They are meant to be spacers for greater flexibility and mobility of the spine. It is the curves in the spine, the lordosis and the cervical and and the lumbar spine, as well as the kyphosis. The spine acts as a giant spring that the forces and stresses are absorbed by the muscles, ligaments, and tendons, and the curve itself as a giant spring. If you lose the normal curves in the spine, that's when you start putting the abnormal stress onto the discs, and then they become the shock absorbers, which they cannot handle, and then they start to degenerate and herniate. So stop focusing on herniated discs as the cause. Why? What caused the disc to herniate? When I asked the other clinicians what caused that disc to herniate, I always get very vague answers. No, they can't really tell me, and they can't tell the patient. And I've had patients have treated, oh, yeah, I've had a herniated disc for 20 years. Why is that disc not healing? What's stopping it from healing? Because we're not treating the underlying cause of what caused that disc to herniate in the first place. So whether you're using X-rays, CAT scans, MRIs, you cannot see the pain on an X-ray, on these imaging. You can only see a static picture of what's going on in the moment for any given patient. So the X-rays and imaging show the effects of the dysfunction, not the cause of the dysfunction. So if we have this patient walking into the clinic and their knees look like this, my question to you is, do we need to take this X-ray? Absolutely not. We don't need to take this X-ray. We know there's going to be this dysfunction. So why are you taking an X-ray? We would just go ahead and treat the dysfunction first and see if they respond. If they respond, then there's no need to take the MRI or X-ray, whatever imaging you think is needed. And by the way, these are the guidelines that are being passed. If you haven't noticed that in your clinic yet, it is absolutely coming that they're telling you to treat first, image later, unless you've had acute trauma. So if you've got acute trauma, or there's a lot of heat, or there's some other significant red flag, it's okay to treat first, and then if they're not responding, then do the imaging. So you look at this young girl, she's only 12, 13 years old. Does that look normal posture to you? Not even close. It's this kyphosis in the neck instead of the proper lordosis that's a problem. But if you remember me in the beginning where I was saying you need to ask better questions and observe. Let me ask you a question. Does anybody observe anything abnormal besides this bad posture or this reverse curve in the neck? How about this big swollen lump in the neck right here? In a young child like this, you absolutely would need to worry about cancer or thyroid. And she had already had tests done on this and it was negative. This kind of neck problem absolutely can cause that, but you should have observed this. And these are the kind of things that are important to pay attention to. When it comes to imaging, you should always, if possible, have the patient have their x-rays done standing. This is a patient that walked in with really bad, severe knee pain and had trouble walking. And this was their x-rays done that were done lying down. And I said, okay, we really need to see what your knees look like standing. So we did send for her for x-rays later after about 2 weeks of treatment. And we can see dramatic change in the medial compartment. We see this joint space in here. What looked fairly normal here completely disappears as soon as you load the gait. And this is exactly what we saw in their weight-bearing stance. So if you're going to do the x-rays, make sure they're done standing and weight-bearing. X-rays done lying down are almost worthless if you're not suspecting a fracture or cancer. So physical tests are designed to assess the areas. So you see this curvature, what are you going to do about it? You see this spinal cord compression in here. What are you going to do about it? Is this emergency surgery? No, we treat these all the time in the clinic. The key is can we get it better? You need to monitor that patient. Are they getting better, worse, or staying the same? If they're not responding to treatment, these are the kind of case that would be potential surgical cases, but we do treat these and successfully. So the physical problems need physical solutions. We're using by the way, if you're not familiar with kinetic chains, the kinetic chain is, you've got four of them, two upper, two lower. And the lower kinetic chain is anything from your toes to your lumbar spine. And the upper kinetic chain is anything from your fingertips to your cervical and thoracic spine. And it's anything in between. And the principle is this: any joint or structure in that chain cannot affect on any other joint or structure. So if you're dealing with lower back, you need to address the knee, the hip, the foot. You need to assess it and to find out if any of those joints or tissues in that area are a problem. And then using a variety of techniques. This is why it's important to know what tissue is involved. Is it the joint? Chiropractic is awesome for the joint. What about muscle? There's a variety of muscle therapy techniques. I've got a specialized neuromuscular integration technique uh, that we use. You can think of as a deep tissue massage, uh, muscle physiology, stretching, and using adjunctive therapies, and then trying to readdress patients' gait and posture. A couple quick things to wrap things up. Another major problem in rehabilitation, it drives me crazy. We talk about, oh, you need to strengthen muscles, strengthen muscles, strengthen muscles. I treated hundreds of professional athletes, and I can't begin to tell you how many come in and say, yeah, my trainer, my doctor said I've got a week this, week that. There is almost no professional athlete that's going to have a week anything. As muscles become really tight, more spastic, they actually become weaker. Who's really strong for their size? Martial artists and gymnasts. Why? Because they work as much on their flexibility as their strength. So when you start working on creating strengthening exercises, muscles, as they get stronger, create greater compressive forces on the joints. And if these muscles are in a state of excessive contraction while at rest, then they're constantly putting compressive forces on those joints, which leads to accelerated degeneration. So when it comes to the spine and we talk about core strengthening, we absolutely need to get away from core strengthening. Postural muscles are not meant for strength. They are meant for endurance. It's like the difference between running a sprint versus a marathon. You need to make sure that the postural muscles are not overly strong, overly tense, and that they're in a state of relative relaxation unless they're needing to be in a state of endurance contractions. So if you have a lot of strengthening and really tight lower back muscles, you have constant compressive force on the disc, the SI joints, the hip joints, and this is why we see such a prevalence of high lower back pain, even though we're trying to treat these patients. So we need to understand movement patterns and the kinetic function. So here's the last patient. This guy was pretty much bedridden or left in a wheelchair. They had him on Parkinson's medication, but he really wasn't a Parkinson's patient. It was undiagnosed, a combination of lower back issues as well as neck problems. And when you're addressing the whole kinetic chain, you can really make some pretty dramatic changes. Do not assume that just because somebody's got uh, been diagnosed with Parkinson's or some other MS or some other degenerative disease, the question is, why do they have it? And if we apply proper anatomy, physiology, biomechanics, neurology to these patients, we can really make a big difference. And so, this is just another one of the athletes I traded. This guy's like a phenomenal fighter, pound for pound, second strongest fighter in the world. Um, he was a Brazilian jiu-jitsu fighter. These guys take a massive beating in the ring and with their training. But with proper rehabilitation, you can keep these guys in the ring, keep them active in their sports, and keep them off the injury list. So I appreciate your time. If there's anybody that has any questions, you can feel free to contact me, send me an email. But I'm passionate about this because of my own pain and suffering. So I hope we start opening up. We need to address the fact we might not be doing what's best for the patient and the results we're getting, and we can do better. Thank you.
Yes. Thank you. Thank you so much, sir. It was a nice presentation. Any questions regarding this topic? Any questions? If you have any questions regarding this topic, you can text us immediately in the chat box. We'll be asking behalf of you.
Okay. Thank you.
Yes, thank you so much, sir. It was a nice presentation, and hope you'll get. Hope we expect your presence for next year in face-to-face meeting,
Thank you.
and you'll be getting the participation certificate and booklet within a couple of days. Thank you so much.
Thanks.
So next speaker, another keynote speaker of the day is Dr. Mike Stender, the University of Nevada, Las Vegas, USA. The title will be Neurons, the Errors Together, Terror Together, Unlocking the Mysterious in Rehabilitation and the WIPs for Other Movement and Disorders. Yes, sir, you can go ahead.
Thank you so much, and it's my pleasure to be here with you today. Neurons that error together when we make mistakes in playing music or on the sports field, the pitch, the diamond, and the court, these neurons begin to terror together. Let's talk about unlocking the mysteries in rehabilitation, especially as related to these functional neurologic disorders in sport. Very briefly, my name is Mike Studer, physical therapist for the past 35 years. I've lectured in all 50 states, 14 countries, and 5 continents. And perhaps most importantly for today's topic, I've been studying functional movement disorders, including the yips, for the past 42 years. Yes, preceding my time as a physical therapist. Here's a little bit about that. But before we get into that, my contact information is here for you below. If you want to email me or reach out via social media or otherwise, you have that contact information at your latitude. Okay, well, here's me circled right here, sophomore starting third baseman, YIP survivor, 1985 high school state championship. And yes, it was well known that I had the yips. I didn't know it, but I started studying the yips at that point in 1985. Let's give a brief overview of where we're headed today. We're going to talk about movement disorders across the different sports and look at the physiology and actually the neurology of these. Then we're going to actually talk about the fact that these are more than just the yips, and we're going to look at the different related phenotypes of this. And then finally, and most importantly, understanding how to return these athletes back to their sport or competition. These are not psychological problems. These are actually functional problems. Here in the upper left-hand corner, look at the horse. An exaggerated movement, uncertain about the clearance of the barrier, clearly has an inappropriate response that's excessive to the environmental demands. We see Simone Biles having her very classic experience with the twisties in the Tokyo 2020 Olympics. We see Chuck Knobloch here being denigrated on Sports Illustrated, called a blockhead. And at some point, these had thought to be mistakenly attributed to be psychological problems. Here's Andre Agassi mocking his opponent, who was having the yips with ball toss on serve in tennis. He's actually mocking his opponent, and here the head judge is actually concerned about what Agassi's trying to do. So it doesn't matter whether you've learned about this from Simone Biles, from Rick Ankiel, from Ted Lasso, or from professional golf. These are all the same type of related functional movement disorders in sport, FMDAs. Now, these are not choking, and there is a clear difference as these athletes are experiencing involuntary movements that are beyond just making mistakes. Their body is not behaving in the manner that they are normally highly skilled and capable of controlling. Sometimes it happens under pressure. Sometimes it actually happens less as the pressure elevates. These are not psychological problems. Here again, this is Agassi intentionally having his fun with his opponent, mocking his difficulties with toss. This creates a stigma of mentally being too weak to handle the pressure. We see this now being pervade even into the widely popular sport of pickleball. And here's where we see that they're omnipresent and not just a function of pressure. They're functional, they come and go, they're variable, they can be stigmatized, they can decrease with pressure, they can come on with pressure, but your body is moving in an involuntary manner. You're not just not able to hit the putt, you shank it wildly because your hands are not under your full volitional control. You don't just miss the throw, you throw it up into the stands. That's why this is a functional movement disorder, not just a choking under pressure, not being able to hit against this pitcher. Dr. Tom Ferraro, who's widely published on this matter, says, and I quote, "This is a sudden loss of fine motor skills. Remember, that also can happen in musical performance that comes on without apparent explanation and is usually suffered by mature athletes with years of experience. Often the athlete experiences them when under great pressure, and they report feelings of being frozen, helpless, and ashamed. They will often change techniques in order to avoid the issue." We're talking about the yips, the jerks, freezing, motare, which is in archery, the staggers, dartitis, actually in throwing darts. I'm not making these terms up. The visitor, flinching, the twisties, the creature, which was one of the first monikers assigned to Steve Blass when he was having these problems pitching for the Pittsburgh Pirates in the 1960s, whiskey fingers, the waggles, cuitis, which occurs in pool, panic, and fleeky camo, which refers to being unable to handle backwards movements. Typically, that is going to be a handspring, somersault, or back dive. So when we look at all of these across the different variables of court, sport, pool, springboard, and field, we understand these are where the common terms sort out. Without reading these through, I'll leave the handout to you, or if anyone would like a copy of this, I'm happy to receive your request by email. Let's understand it a little bit more closely neurophysiologically. Your attention center says, watch out and prevent errors at all cost. Your cerebellum says, that's not what I expected to happen. And from a memory and amygdala standpoint, fear center, oversimplified, we understand that the emotions associated are something that we would like to avoid from happening again. So essentially, neurophysiologically, it's going to look like this, and I'm going to explain that point by point by explaining to you what we're looking at, again, according to Ted Lasso, is something that has been largely taboo to talk about. We're talking about the yips, intermittent, involuntary, and may in fact reduce when we're distracted and focused in a flow state under extreme pressure. Now, the words that we choose do matter. These can be all considered a functional neurologic disorder. There's some recent pushback with consideration for a few of the subtypes to be considered functional symptom disorders, specifically like a functional cognitive disorder, a persistent postural perceptual dizziness, and even considerations of hypochondriacal behavior. These are all somewhat related and beyond the scope of what we have time to cover today, but I want to bring into this novel and expanding consideration. The commonality and the reason why we bring this up is the hyperfixation on an error that we have committed. So this happens across the spectrum and across the lifespan, from fear of falling to choking under pressure, as Harris and colleagues alerted us to the commonalities of these features. I don't want to walk, I might fall. I don't want to play anymore, I might be embarrassed. So the excessive internal self-focus based on an error that you've experienced or fear now of an error occurring, like a fall or like an embarrassing performance in sport. So now let's look even deeper at the physiology and neurophysiology. As I promised, we know that we've got 83 billion neurons, and imagine each one of those can make anywhere from 2 connections to 100,000 connections. There's plenty of room for maladaptive or negative neuroplasticity, a way to go from MVP to FMD, again, functional movement disorder. You saw the arrows earlier. I'm going to draw them out for you now and label them. Perhaps you have a motor plan. The cerebellum receives the copy of that and says, that's not exactly what I expected. Your amygdala says, should we be alarmed about the difference between what was planned and what was expected? Sometimes that difference is a good thing. We make adjustments according to updates in the task or the environment. If it's not a good thing, we may receive alarm, and we may then upregulate our attention center for some predictive processing. I want you to hold on to that term, because that tells us, in fact, that we have to watch out for the next time we enact that motor program. Again, I'm being reductive and oversimplifying here for the sake of time. We need to add some alarm because the last time it included error. After a period of time, too many frequencies or repetitions of errors, we then begin to have a negative neuroplasticity in the right temporoparietal junction, because we begin to actually create a dysregulated perceptions of ourselves. We lose self-efficacy. We have less accuracy of kinesthetically where our body is, and we lose schema in the extrastriate body area here in the right TPJ. You'll notice this is labeled on the left hemisphere right now. We're going to reverse that in a moment intentionally. So the motor plan, free throw, dive, or flip, has an unexpected error. We're alarmed by that. We upregulate our attention, and therefore we start to feel that we have no sense of or rightful presence of confidence regarding where our body is, hands are, feet are, etc. Therefore, in fact, this upregulated control leading to the dysregulated perception of self is in fact the ultimate negative neuroplasticity that occurs in the TPJ. Now, let's flip that around and throw it over to the right temporoparietal junction, where regardless of your handedness, largely we can predict your body schema lives right about here, as you see the right temporoparietal junction. This may look somewhat like this, a vicious cycle. So we have a yip, an error, perhaps a fleeky commo, a twisty error. You have that fear of missing again that lives in the amygdala and associated limbic system. You want to avoid embarrassment, so you upregulate your attention center. And now, rather than allowing your basal ganglia to ride through a motor program that you know well, your dorsolateral prefrontal cortex, supplementary motor area, premotor cortex decide they're going to add conscious control, and you're going to think about the movement, how you throw, how you putt, etc. Now you have yips because you're no longer processing it in your centers of automaticity. You fail again, you're embarrassed again, you upregulate the amygdala and the attention center, you start to label yourself as a failure, and you start to cycle viciously all over again. So there becomes a link between this high performance and internal or external stressor with the stigma of I should be able to do this. The vicious cycle occurs when you know you've done this activity millions of times and you're capable of doing it, and now you seemingly have forgotten how to run, how to throw, how to play the piano, how to, in fact, create that note on your guitar, or in fact, stemming back to athletics, how to flip, how to dive, how to release an arrow. So this all comes down into what neurons become wired together dysfunctionally. Again, oversimplifying and in a reductive fashion, neurons that fire together, wired together, which you'll see was the play on words for my title, neurons that error together, terror together. We make the error, we begin to have a fear-based cycle now associated with the movement. So when you try to do this, you fail. And now even the consideration that it's time to play, to practice, you in fact are already associating that sense of elevated cortisol and all of the sympathetic nervous system that goes with that because of your past experiences. So the order of neuroplastic change is important here. Remember, in a positive fashion, neuroplasticity includes a significant stimulus that's been repeated, that gives us an opportunity to consolidate, to create a long-term potentiation, and to finally create an automaticity relationship, degree of procedural or implicit movement associated, so we begin to feel that we can perform on autopilot. However, if in fact you're not having success, the same thing happens when you've experienced an error. The sufficient stimulus and repetitions of that error now become the neuroplastic learned network. So we have a maladaptive brain that is trained to protect us and to be watchful for things that feel painful, feel like it causes us nausea, or potentially could be poisonous. That's very primitive. Now we're trained to protect ourselves, even in a biopsychosocial manner, to consider how did we feel and protect against future embarrassment. So a mere suggestion of the activity, could you ride in the back of the car, could create a sensory learning maladaptive neuroplastic network with an individual who expects nausea. In the same exact case, for a person with a functional neurologic disorder, they step up to the plate and they expect failure. So grab a bat, you're up. Or next up on the 10-meter board comes over the announcement, or you have a game today, you're already beginning to taste failure at that point. So these become associated with all three memory types: fact-based, semantic-based memories, episodic memories, and movement-based memories. These actually create dysfunctional neuroplasticity, as we suggested earlier, with elevated sensory receptors, sympathetic-based potentiation, according to our cortisol HPA axis, and the litany of the rest. So even if you have not injured yourself or have not committed an error, the neuroplasticity becomes let's just say, continue to be strengthened and wired together because you have a confirmation bias and you begin to watch for all potential errors. So let's move into part 3 in our remaining time and find out how to unwind or unwire together these neurons that should not be together. Here is the 5-point pathway forward when we're talking about individuals that potentially are working on putting, or in fact, potentially even putting it into action. The intentional play on words there with both of those for one of the most prolific and prevalent experiences of the yips, and that is putting in golf. Exposure to the provoking movement away from the sport. Use something other than a golf club. Try a cricket mallet. A croquet mallet, or something of that sort that could give you an opportunity to be playful, to not have the same expectations. Begin to measure your performance with that similar but not same event, croquet mallet. Distract with overtraining. Try to do it with your eyes closed, with different weighted balls, different height of grass, for example. Overtrain, weights on the wrist, etc. Demonstrate improvement away from the sport and then gradually come back to the sport. What we utilize for these athletes is both a top-down and bottom-up approach. The acceptance and commitment therapy, cognitive behavioral therapy, learning sequences and learning strategies. I've checked the boxes and done everything that I can. Have an external focus on the whole, not my hands at the putting. The rationalization, I'm very good at this. I've done this thousands of times. I've practiced. I'm going to be fine. And a distraction. Now, we must additionally utilize for some individuals, and we select from these options a person-specific approach to potentially change the club entirely, change your putter, change your grip, change your hand pressure, reduce the dominant hand, separate your hands, use breathing, or potentially pose and hold the finish. All of those are bottom up. Apologies, just as a function of time, I don't have time to go through all of these. In gymnastics, we'll use a similar approach, only slightly different, top down and bottom up. You'll see very similar approaches. And again, if you want these slides, please just email me. I won't be able to go through all of these, but you'll notice we're actually using some sensory strategies over here in the bottom up. And we're also utilizing music would be appropriate in gymnastics, especially in practice, as compared to in golf. How about returning to the diamond? One of my most recent and most famous patients, who will remain unnamed, 29-year-old male, very competitive baseball player, could not hold on to the baseball bat, ruled out all of the common causes, and in fact, was able to return using this same approach. Did not let him hold on to a baseball bat, moved to different things, top golf, swinging right-handed and left-handed, using tennis rackets, using pickleball paddles, etc. Was able to hold on to those just fine, proved to himself that he had the capacities, transition back on to the diamond. Same thing with a 20-year-old female competitive soccer player who could not lift her left foot after ACL. And this was a rather sudden interruption in what was an otherwise successful rehabilitative venture. We used exposure away from soccer, then back to sport, distracting with overtraining, gamification. Actually, hopscotch was very healthy for her, and other gamified experiences using a Wii board. How about a 17-year-old female competitive high school diver and cheerleader who suddenly lost her ability to do anything that was backwards in orientation, could not do backflips, hands, backsprings, flips, or somersaults. We gave her a competition type approach to gamify. So here she is experiencing that freezing actually up on a board, not being able to release and actually do a very simple back dive in practice. What did we do? If you look over here, she gamified where she tried to max out and create a competitive experience so that she had to try to see how many successful back dives she could do in 1 minute. So if she got one right, she had to not think about it. Or if she got one wrong, she couldn't think about it. She needed to quickly go to the next one. There you see she got one right. She goes right back. You can see the dopamine. Now she's attaching to the movement again. She's not getting a chance to think internally and go up to attention and dorsolateral prefrontal cortex. She's going right back down to basal ganglia, centers of automaticity. All right, so as we begin to wrap up in part 3, we expose to the provoking movement away from the sport or context. We measure that performance when plausible, compete against that measure away from the sport. We distract with overtraining, just like you saw here in gamification. We demonstrate improvement, and then we progress back to sport. This is Hebbian relearning, fire together, and rewire together. We want success to come from the basal ganglia to the cerebellum to the nucleus accumbens and back to the basal ganglia. We want endogenous dopamine, we want implicit learning, and we want a very tight neural structure that's a quiet brain and not scattered up, including dorsolateral prefrontal cortex, temporoparietal junction, or amygdala. So here's what we do want, and that's how we get it without that attention center. Again, to end on time and ask for questions at this point, I'll leave you with my slide here of how to reach me or follow me. And again, with some tongue-in-cheek, I'll say thank you for your attention to these conditions. I'll pause here and then ask for any questions then as well.
Any questions regarding this topic? Even if you are having any questions regarding this topic, you can text us. So we can ask behalf of you.
Thank you. I'll wait for your emails. I appreciate being a part of the conference.
Thank you. Thank you so much, sir. It was a nice day. And you'll be getting the participation certificate and booklet within a couple of days. Thank you once again. So next speaker will be, we go with Dr. Diksha Singh from OBGYN Chondro Wing from India.
Thank you. So should I start sharing my screen?
Yes.
Thank you. Just give me a minute.
Yes, madam. You can start sharing your slide.
Yeah. Okay. Can you see my screen?
No. You can find the share.
Yeah, I'm sharing with that only. I don't know how come. Give me a minute. I think I don't know why failing from my lab. Can you just share it on behalf of me, please? Because I'm trying for third time. Yeah, are you sharing?
Yes, ma'am.
Yeah, thank you so much.
So just let me know, slide
Yeah,
share.
sure. Thank you so much.
Yes. After every slide, just to mention slide.
Sure. Thank you.
Yes, you can go ahead.
Yeah. So yeah. So this is my topic: predict analytics in sports rehab, AI models for female injury risk and management. And I'm Dr. Diksha Singh, an Opskynic PT, founder of Hormonal Wing, and a published author from India. And thank you so much for having me here. So let's start. Next slide, please. Yeah. So why to focus on, my main topic as an OBGYN, I always talk about the women's health, and when we talk about the sports and when we see many of the protocol, rehab protocol, which we are following from the past traditional time. So they are focused not on gender specific. So when we are talking about the kind of gender specific women, we have lots of hormonal changes throughout month. They are going through different hormones. Muscles are not behaving up to the same as they are behaving in the past. So definitely throughout month they are going like this according to their hormone and according to their muscle also. So female athletes are up to 8 times more likely to suffer ACL injuries. So now we are going to discuss, okay, why focus on female athlete injury risk. So like hormonal fluctuation, as I have told you, ki like this, ki we can talk about ki how this is going like this from zero to high, then again to zero. Is throughout month the women is going from starting from 0 to 100, then again to 0. So this is how hormonal fluctuation impacting her neuromuscular control. And your menstrual hormone fluctuations influence joint laxity and neuromuscular control. And also the biomechanical differences like her wider Q angle and lower limb alignment contribute to injury risk than the male person. And existing rehab protocol, as I told you, are not gender specific, leading to incomplete recovery. So as AI can bridge this gap by offering cycle aware personalized rehab plan, and AI allows cycle aware and predictive rehab. And okay, when we are working with that sports person, that women, so we are more aware. Okay, now this is the time of her menstrual cycle or her follicular phase or her luteal phase or her ovulation time. So we'll get to know, okay, what rehab plan we can select according to your hormone or her kind of nature of behavior of her muscle. So next slide, please. Yeah. So what are these are our study objectives, like to identify injury risk windows using AI algorithm and female specific data, and to build a menstrual phase responsive rehab framework. So as I told you, okay, this is like a kind, you can just imagine it, there are four throughout month. There are four phases. First is menstrual, second follicular, third ovulation, and fourth is your luteal phase. So according to these phases, these cycle phases, we are having a personalized rehab plan and to reduce recurring injuries in active athletes, which is productive. They're going to achieve many things, but because of the injuries, they are lacking the ground. So to establish a reproducive model and clinical protocols, so that we can actually work with those who are good at their kind of sports they are into. And we can specify more into, okay, like this is the individualized plan according to their gender and their sports also. So next plan, please. Next slide. So our study design and sample, we just chosen 65 athletes age around 18 to 28. These are mostly footballers, gymnasts, and runners. So tools we have used is like EMG, hormone tracker, and inertial unit. Because not every time every woman in the group is going through the same phase. They are having the same, different phases. So we have to track their hormone to know, okay, what's the nature or the behavior of the muscle. Because as we know, there are the four phases. So in the very first phase, because of the all fatigue and lacking, the muscle is behaving too low, or like hypo muscles are there. Then kind of fatigue is there, and kind of balance activity is not going to be not good in follicular phase. Then again that muscle is going to gain strength and going to behave hyperactive. So at that moment, stretching is not beneficial for that sports person. So these are like the tools will help us. And AI models, XGBoost, Random Forest, and also there one more like a logistic progression. We has like identified those like footballers, gymnasts, and runners. And in those, we got prediction accuracy up to like it's more than 85% for non-contact injury prediction we have created through all this. So next slide, please. Yeah. Now, menstrual phase versus injuries. When we talk about the menstrual phase, we are talking about these four phases like ovulatory, follicular, late luteal, and cycle based. So, ovulatory, there's high estrogen and chances of getting more, like a woman is getting more chances to get pregnant. So, definitely progesterone is going to be more high. So, ligament laxity. So, to get the body prepared to conceive. So ligament laxity means hyperactivity of muscle. Muscle is behaving too like kind of tight muscle are there in form of ovulation. Then when we talk about follicular, is low strength and high fatigue. The woman is getting easily fatigued. She didn't want to do anything. She want to only sleep, rest. She's more kind of dehydrated at that moment if she's not drinking water well. Then late luteal thermoregulatory strain increases means kind of she's kind of having not having good mood and body type. She's like always kind of like falling and more prone to injuries at that moment. Cycle based care boosts compliance and recovery. So when we know about, okay, now when we can track the cycle and we know, okay, this is the phase, this is like going, the woman is going, this woman is going through this phase, so we can easily predict. Okay, and we can avoid that injury risk. Okay, next. Now AI model and result. So when we do all those like subject, we go through all those data according to their hormone cycle and their menstrual cycle. So 78% injury prediction accuracy is there approximately, and 62% fewer injuries in AI based rehab group. So we just like compare the group. Okay, this is how they are behaving in the past and now how they are behaving. And variable data enhanced prediction by 12%. Also, as I can see, we can observe the kind of confidence is more in them. And cycle phase risk aligned with movement asymmetries. As kind of post COVID, as I'm seeing in my OPD, the chances of getting like those of PCOS is more there. So they are more prone to kind of their phases is not accurate. Ovulation is not happening every month in case of PCOS. So that moment, this cycle tracking will give their monthly health window and health report also. Okay, next. Yeah. Now this is the case study of footballer age 23. So like 4 ankle sprain in 6 months and mid-cycle. So AI flex here kind of pelvic sway and valgus combo. Kind of means you can just look at this key. Okay, kind of anatomical, muscular, and hormonal level. We are taking the every aspect. Our interventions, taping views, drills, cycle aware loading, and result no injuries, agility increases, kind of her performance increases so much. Next. Yeah, cycle specific rehab protocol flow. So first, cycle tracking plus movement screening. Second step is AI analysis and preventive risk score. So when we are tracking, to definitely the person is much more aware. Okay, what is happening with my body, what is going inside and outside my body. And step 3, tailored exercises like stability, mobility, and load mobilization. So we just tailored that rehab plan. And step 4 is wearable monitoring. Kind of we educate athlete plus monitor real time versus wearable. Okay, when they are not wearing anything and when they are wearing, what's the difference they are getting? We are educating and giving them kind of biofeedback also. And step 5 is update plan BI weekly based on cycle plus AI feedback. So this is like kind of specific rehab protocol flow. Kind of we are tracking their menstrual cycle. Then we are risking like okay, knowing okay this is a risk factor. We are scoring it. Then we are tailoring the rehab plan according to their muscle hormone. We are now again comparing and giving them the weekly plan to enhance their performance. Next slide. Now, applications and future scope. like used in clinics, leagues, training academies. See, as a researcher and as a clinician, I'm using in my clinical exposure only, and mobile integration for athlete plus physio feedback in form of like app you can go for, or real-time feedback to athlete plus your physiotherapist also, and can reduce dropout from sports due to chronic pain or repetitive injury. Your support chronic pain and dropout prevention, and also potential integration with hormonal therapy and emotional resilience coaching, and encourage a shift toward female-centered physiotherapy framework. Means we are merging here with hormonal, physical, and emotional care. Okay, next slide, please. So before giving this, I just want to again recollect everything. Okay, this is like there are four throughout a month. There are like for example, 30 days. So few days starting week is for a menstrual, your first menstrual cycle of that woman. Then followed by the follicular phase, then your ovulation, then the luteal phase. Then again, if she is not getting pregnant, she's not conceiving, back to zero, to menstrual cycle. Means once her muscle is behaving in a menstrual time, is more hypoactive kind of loose behavior is there, she will feel kind of easily cramp, dehydration, she didn't want to do anything. Then follicular phase hormone is like, okay, now hormone is settling up again, and again your uterus and ovary is preparing. So here she's getting more fatigued. Then we are moving toward the ovulation, she's on cloud nine, definitely she want to overcome anything. So we can face this cycle. And luteal phase, her muscle is behaving hyperactive, means kind of strength is here but too tight is there. So definitely if throughout the phase we know the hormone cycle, we know everything, so we can help her more, and with the proper tailored program. And female specific rehab is essential. This is the takeaway from my end. And AI is equal to precision plus prevention. It's just saving our time and saving that person also from different injuries. And women deserve gender specific sport rehab protocol, AI enable predictive cycle informed care, and understand hormonal rhythm is like equal to your better recovery. That sports girl or woman, and empowering athlete with knowledge of their body is equal to performance plus safety. Because most of time that woman who is playing, who is into the sports, they're not more into like a kind of their knowing about their body. Okay, how is their pelvis different from the male, or their component, how their energy is different, how their hormone cycle is different, how their muscle behavior is different throughout the month. So definitely your performance plus safety is equal to more enhanced performance, and risk of like kind of injury is less in that case. And personalized rehab is not a luxury, it's essential. So tech enabled healing is the future of care. So next slide, please. Yeah. So thank you. And this is kind of as I told you, I'm founder of Hormonal Wing. So this is my email and my Instagram, and let's empower women in sports rehab. And just soon, within this week only, I think my this book is going to be in market, AI in healthcare and physiotherapy with smart healing. So if you want, you can go through that book also. And thank you so much for having me here and for my this research topic.
These are the presentation from Dr. Diksha Singh. Any questions regarding this topic? Any questions? If you have any questions regarding this topic, yes, you can text here in chat box. We'll be asking behalf of you, even after the completion of the Congress. Yes, there's no question here. So next speaker of the day, we request Dr. Mariana R.C. Aquene from the Universidade Federal Minas from Brazil. The topic will be changes in joint and coordinating and regularity following running to distinguished runners who sustained their injury within 6 months.
Hello, can you see my screen?
Yes, ma'am.
Okay, can I start?
Yes, you can go ahead.
Hello, everyone. My name is Mariana Aquino. I'm here representing the Program of Rehabilitation Science of Federal University of Minas Gerais in Brazil. Today, I'm presenting part of my doctorate thesis named Change in Joint and Coordination Regularity After Running Distinguished Runners Who Sustain an Injury Within 6 months. Running is a common cause of exercise-related musculoskeletal injuries with high rates of injuries reported every year. We know that musculoskeletal injuries are a multifactorial process, often related to the inability to overcome and recover from the continuous demand imposed by training and exercise. However, since it's impossible to obtain sufficient information about the many factors related to injury occurrence, tools and concepts from complex dynamical system could improve the understanding of the role of movement change in response to exercise and help to forecast injuries. For example, the same exercise that could induce change in one group may not change the movement dynamics in another group. For example, injury-prone individuals or injured individuals compared to non-injured ones. Therefore, athletes at risk of injury may show early signs of reduced capacity when exposed to fatigue. So, exercise-induced change in movement dynamics may distinguish runners with reduced adaptive capacity and indicate imminent injury. Therefore, this study aimed to investigate whether acute and prolonged change in joint and coordination regularity during a single-leg squat test after running distinguished runners who sustain or not an injury within 6 months. We included 33 runners, adults, healthy ones, who ran at least 20 kilometers a week, twice a week, for a minimum of 6 months. We had to exclude 3 participants due to data loss, failed to attend, or presenting pain during the assessments. Participants were evaluated during 4 weeks. 2 visits of testing were completing during the first week to collect intake information, practice the single leg squat test, and perform the VO2 max test. And the VO2 max was used to define the intensity and the speed of the protocol for each participant. During weeks 2 to 4, the participants performed 3 protocols, running in moderate intensity, high intensity, and control protocol, all in randomized order. They also performed the single leg squat test before, after, 24 and 48 hours after each protocol. After 6 months, the participants responded to an injury survey, and they were divided into 2 groups: the individuals who sustained an injury within 6 months after the assessment, and the individuals who did not sustain an injury. The single leg squat test consisted of 60 seconds interrupted squats of self-selected speed, and the participants were instructed to stand barefoot over their dominant leg in front of the screen with 2 horizontal lines that were top and bottom targets. The distance between the participant and the screen was adjusted to ensure that a minimum of 40 degrees of knee flexion was required to complete each squat repetition. A laser pointer was attached to a rigid cluster, and the runners were instructed to flex and stand their dominant lower limb. And to complete the task, the participants had to continuously move the laser from the lower to the top targets. The single leg squat test was assessed using 3D motion capture with 33 reflective markers. We focus on analyzing 2 joints, ankle and knee, joint angles in sagittal plane. We use both joints to calculate joint coordination. Joint coordination was calculated using continuous relative phase based on Hilbert transform, and the continuous relative phase quantifies the relationship between 2 joints or 2 segments. Here we use the ankle dorsiflexion and plantar flexion, and the knee extension and flexion angles. The difference in phase angles of 2 the original signals generates a new time series corresponding to the relative phase angle between the joint analyzed. So the new time series corresponding to the ankle-knee coordination has values ranging from 0 degrees to 100 degrees, where 0 degrees represent an in-phase coordination, where the ankle and the knees move in the same direction, and values close to 180 degrees represent anti-phase coordination. We also calculate the regularity of joint angles and joint coordination using an entropy measures. Entropy measures quantify the amount of uncertainty of irregularity of a signal, where higher or lower entropy correspond to a reduce of regularity of an increase of regularity of a signal. Results indicate that this increase of regularity of a signal is related to reduced adaptive capacity, which has been observed in injured individuals or older individuals compared to healthy or younger ones. We use multi-scale entropy to estimate the regularity of the time series at multiple scale using a coarse grain procedure. The multi-scale entropy outcome is the area under the curve of the entropy curves over multiple scale. For example, here we see the MSE index on post-test, and the blue represents the area under the curve, which is the MSE index of post 24 hours. Where higher MSE index indicates higher entropy, so more random dynamics, and lower MSE index indicates lower entropy, and it's related to a more regular dynamics. Characteristics of the injury and the non-injury groups were compared using independent t-tests. Joint and coordination regularity were compared based on percent change of relative change relative to the pre-test. That is, negative and positive values of this percent change indicate that the post 24 or post 48 hours entropy were lower or higher respectively than the pre-test value. The effect of time, protocol, and group was analyzed with a three-way mixed ANOVA. Additionally, to verify the magnitude of the relative change in joint and coordination, to verify if this magnitude of difference were significant, we compared groups' percent change at each protocol against 0% using a one sample t-test. 33 runners, that is related to 43.3% of our sample, reporting sustaining an injury between 1 to 5 months. And all reported injuries were running related overuse injuries. Our results shows a time effect at the ankle and knee entropy, indicating a decrease of MSE index after 48 hours compared to the post-test change independently of the protocol. The ANOVA also revealed a time effect in the ankle and knee at the coordination regularity, ankle-knee coordination. The time effect demonstrates a decrease of entropy at post-test compared to 24 and 48 hours. We also had a group effect, that is, the groups were differently on ankle-knee coordination, independent of the protocol or time. And we also had ankle-knee, a time protocol at ankle-knee coordination effect, indicating that the decrease of entropy was only at the moderate and high intensity. That is, no difference were observed after the control protocol. Observing the magnitude of the relative change in joint regularity, what we observe is that only the non-injury group in high intensity has an increase in entropy. So we have an increase of around 12% compared to 0 and compared to the pre-test. We see the same thing that on the knee entropy, that is, only the non-injury group increased knee entropy immediately after the high intensity running, contrary, the injury group seems to demonstrate a prolonged effect of a high-intensity running at knee entropy with a decrease of entropy around 11%, both at post-24 and post-48 hours. Regarding the joint coordination, only the injury group reduced ankle-knee coordination after the exercise, even at the moderate intensity. Still, both groups demonstrated immediate effect of high-intensity running, but only the injury group maintained the lower entropy after 48 hours. In sum, when we observe all results together, we notice that only the group who was prone to injury was impacted by the moderate intensity exercise. Additionally, during the high intensity running, besides both group was impacted on coordination regularity, the non-injury group seems to compensate the reduction in ankle-knee entropy, the coordination entropy, by increasing the entropy in the joints. Still, only the injury groups appears to have an ongoing recovery process even after 48 hours. So our key results shows that changes in joint and coordination regularity were different between injury and non-injury groups following both running protocols. So coordination changes may constrain the available degrees of freedom and induce the emergence of different solutions for the same task. For instance, ankle-knee coordination became more regular in both groups immediately after the high-intensity protocol. But joint and coordination regularity maintained increase after 24 and 48 hours only in the injury group. That could indicate that those individuals were already with a reduced capacity, and after they've been fatigued after running, we could have like an increase of muscle inflammatory response within 12 hours with peak at post for 8 hours, reducing even more their capacity to adapt to exercise. And that could be demonstrated by the increase in joint and coordination regularity even after 48 hours. That could mean that those individuals need an increase on the recovery time. We also noticed that the non-injury group increased joint entropy. That means they were less regular after high-intensity run, only at joint regularity. So this decrease in joint regularity could mean an increase of adaptive behavior or less constrained behavior, indicating that healthy runners after fatigue have this different strategy to deal with fatigue or exercise. So runners who did not become injured have different response from high-intensity runners than injury runners. So looking closer to that, the non-injury runners appear to compensate the reduction in coordination entropy by increasing the joint entropy after running at high intensity. So this increase in coordination may have been to compensate the decrease in joint regulation. To confirm this reasoning, we run a correlation analysis between the percent change in ankle-knee relative phase entropy and the sum of the percent change in ankle and knee entropy on post-test relative to pre-test. We observe that changes in ankle-knee entropy were inversely and highly correlated with changes in joint entropy in the non-injury group. Thus, the runners who did not become injured seems to adopt a less constrained behavior and more adaptable behavior in the joints to compensate for the more constrained coordination induced by the high-intensity runner. So this ability to mitigate the deleterious consequence of exercise and fatigue appears to be related to a reduction in injury occurrence. We also observed that only the injury group increased regularity after running at moderate intensity. Moderate intensity exercise, around 65% of VO2 max, can be considered a preferred intensity by sports participants. So these runners with this reduced capacity to adapt to exercise shows an increase in coordination regularity that could be related to a lower adaptive behavior than the healthy individuals, even in a moderate intensity. So runners who sustain an injury may have a reduced capacity to adapt to exercise, even in a more habitual intensity exercise. So our take-home message from our study is that change in joint and coordination regularity during the single leg squat tasks following moderate and high intensity protocols distinguish runners who did and did not become injured within 6 months of assessments. And we observed that because runners who became injured present a more regular and predicted movement dynamics and require more time to recover from running than the non-injured runners. We also observed that looking at the runners with the non-injured group, there were runners with an ability to mitigate and compensate for the effects of running and fatigue, and appears to be less likely to sustain an injury. Another important message is that runners who became injured present a reduced capacity to adapt and recover from running months before the injury occurs. So, even after a protocol resembling habitual training intensity. So if we examining the regularity of joint and coordination during this functional task, that can be useful to track the effect from training and fatigue and help to establish strategies to prevent injuries due to overtraining. Last one, monitoring. We learned that monitoring acute and prolonged within subject change in movement dynamics during a functional task may serve as a screening tool to provide early warnings about the reduced capacity to adapt and recover of runners, which could be associated with future injuries occurrence. I would like to thank you, my colleagues from my lab in Brazil, also from the motor control lab at University of Massachusetts in Amherst. Thank you. Obrigada. That is in Portuguese. Any questions you can send me on email or right here. Thank you so much.
Yes. Any questions regarding this topic? Any questions? Yes, thank you so much, madam. It was a nice presentation. Hope we expect your presence for next year in face-to-face meeting, either in any parts of the world. And you'll be getting the participation certificate and booklet within a couple of days. Thank you once again. Have a nice day.
Thank you.
So we'll go with the next speaker of the conference, who is Dr. Actually, the Dr. Anthony Pimbulla from Andrews University from United States supposed to join. Due to other circumstances, work is unable to join. We'll go with Dr. Luligita from Stange from University of Medicine, Picasso Clinic from Albania. The title will be assessing the impact of PSC growth method versus general exercise on Cope angel reduction in arousals and sclerosis, idiopathic sclerosis.
Hello, everybody.
Yes.
Can I share my screen, please?
Yes, yes.
You can see my screen now?
Yes, madam.
Okay. Hello again. My name is Lulieta Stanai, and I'm here today to present our study titled Assessing the Impact of PSSE Schroth Method versus General Exercises on Cope angle reduction in adolescent idiopathic scoliosis. This study was done with the help of my colleagues, Enkelida Sinai, Nikos Karavidas, and Seida Veizai. And that are my disclosure. I'd like to disclose that I have no financial and non-financial conflict of interest related to this presentation. Let's start with what we already know. As we know, adolescent idiopathic scoliosis is a common spinal deformity that occur mostly in females during the growth. That affect 2 to 3% of adolescents. Mostly of them are females. If we let it untreated, that can cause physical, aesthetic, and psychological impact on the living of them. The aim of the conservative treatment options are to stop the progression and to prevent the progression of the co-bangle and to improve the posture of them in pain and in function. And risk of progression in this age, in adolescence, if we let it untreated, it's really high if the co-bangle is more than 30 degrees. Why early intervention matters? Why we do that? As we know, idiopathic scoliosis can worsen with growth. Large curves lead to health issue in adulthood if we let them untreated. Our goal was to prevent progression and to avoid surgery of them. Some of the conservative treatment, as we know, are different. The first are physiotherapy scoliosis specific exercises. There are different schools now. One of them is PSSE Schroth method that we use in this study, and CIAS, PSPTS, FITS, Schroth, original, etc. These techniques are 3D targeted on correction and stabilization. And after that, some options are general exercises that are based on strengthening and stretching. Bracing are an options too that are used in growing adolescents, mostly on if the co-bangle is 25 degrees to 45 degrees co-bangle. More common bracing are Boston bracing that are rigid bracing, and Shona brace that are 3D brace. Another option is observations that is used for milled curves less than 20 degrees, as the SOSORT recommends, by regular follow-up with imaging, and manual therapy that with manual therapy we cannot correction the curve, but we can relieve the symptoms that are pain or functional. What recent evidence show? We had some controversial studies. For example, the Kuru et al. 2016 suggests that PSSE can reduce the co-bangle and angle of trunk rotation. And Schreiber et al. 2016 also with PSSE plus care, better than standard care that is just observation. Had better results on decrease in angle of trunk rotation and co-bangle. Another study that is okay with our study is Manticone et al. 2014. He said that we had a reduction of co-bangle more than 5 degrees and the results are sustained. But we have a study that tell us that Yatsi et Yaku 2019 that core exercises he compared VCCS, that is PSSE, plus brace, both improve co-bangle more, but core exercises are better than CIAS. What we do suggest in this study, we compare 6-month PSSE Schroth method versus general exercises program in adolescent idiopathic scoliosis. Our hypothesis was that physiotherapy scoliosis specific exercises group will show greater improvements in slowing the progression or in reduction of the co-bangle. Our objective here was to evaluate and to compare the efficacy of physiotherapy scoliosis specific exercises Schroth versus general exercises in reduction of the co-bangle using radiographic parameters as the primary outcome measure. Why is important this parameter? The results will help us understand which approach is preferring in improving the co-bangle in adolescent idiopathic scoliosis. Our method was we randomized we did a randomized control trial from March 2024 to September 2024. We had 30 adolescents aged 10 to 18 years old, diagnosed all with idiopathic scoliosis from a medical. Our inclusion criteria was that we had the Cobb angle 10 to 25 degrees and Reser sign 0 to 3, and angle of trunk rotation greater than 5 degrees. We excluded adolescents that had congenital or neuromuscular scoliosis, leg length discrepancy, or prior surgery of the spine. We took as a better results to if we had a progression or improvement was determined by changes or more or less than 5 degrees. So we need to have changes to 5 degrees that we have progression or increase or decrease of the Cobb angle. We separated them into groups, 15 patients in PSSC Sheriff program. We had 13 girls, 2 boys, mean age 12.9 years, and 15 patients in general exercises group. 12 were girls and 3 boys, mean age 11.9 years. We did for them 2 supervised sections per week, plus we give them home exercises to do 5 home exercises per week at home. This study was done at University Hospital of Trauma when I am a physiotherapist there, and introduction by trained physiotherapists of the PSSC Shroff method. We had ethical approval, University of Medicine protocol number 825/2. We had informed consent obtained by parents or legal guardians. We measured 2 time points, time 0 at baseline and time after the 6 months of the intervention. Our main outcomes were Cobb angle. The Cobb angle, as we know, is a standard radiographic measure used to determine the degree of the spinal curvature in scoliosis. Regarding the Scoliosis Research Society, this is reliable, is consistent and responsive in both surgical and conservative treatment, recommended by SOSWORD, and is used in clinical research worldwide. How we measure that? We take a standing full spine X-ray, anterior-posterior view. We identify the upper and the lower vertebra, the ones most tightly toward the curve. We draw the line along the top of the upper vertebra and along the bottom of the lower vertebra. We draw perpendicular lines to both, and the angle where the intersect is the Cobb angle. Why the posture matters? The patients must stand upright, relaxed, with feet shoulder width apart, arms down for their sides. Any leaning or rotation can distort the angle, leading to inaccurate assessment. So the posture during the X-ray is really necessary. About the intervention, PSSC Shroff method, as I said before, is a conservative 3D approach for idiopathic scoliosis, and the treatment is done in 3D autocorrection, so in frontal plane, in sagittal plane, and in transversal plane. Is self-elongated. Technique is a corrective breathing in them and activity daily living training. Some of the benefits of this technique is reducing pain, improved self-image and posture of the adolescents, slowed the curve progression. As we know, in this age is really important not only to improve the Cobb angle but to slow the curve progression, because we had the high risk in this age, and better quality of life. The other intervention of the other group was general exercises. In general, there are core, strength, and physical activity programs focused on strength, flexibility, endurance, and coordination. This technique is based on international youth activity guidelines, including strengthening, core training, general strength training, and aerobic activities. We did a statistical analysis. We used the software, SPSS software version 25.0. We did the descriptive statistics, mean, plus minus standard deviation for co-bangle. Within group analysis, pair t-test, pre-VC post-intervention, and between groups comparison, independent simple t-test post-intervention. And significant threshold was the p-value less than 0.005. As a result, we assessed for eligibility criteria in total 56 patients. And after excluded 26 for not meeting inclusion criteria, 30 adolescent idiopathic scoliosis were included. 25 of them were females and 5 were males. So we randomized 15 in each group, 15 patients on PSSE short therapy and 15 patients on general exercises group. This is the baseline characteristics of the participants. As we saw here in the right part of the table, we did not have a significant difference between two groups related to age, weight, height, Reser sign, angle of trunk rotation, and co-bangle. So they was pretty much similar in pre-treatment. Here are some results of the PSSE short group. Comparison before and after of some results of the patients. As you saw here, we had more than 5 degrees improvement of the co-bangle, and in the second the same. But if you saw here, we have not too much improvement, but less than 5 degrees we stop the progression. In general exercises group, we have here some images too, Eric's of them, before and after the treatment. As we saw in the middle of the screen, we had here in the thoracic part some increasing of the co-bangle here. So as a result, there was a statistical significant difference in co-bangle within PSSE group. We had 0.004 p-value, and between groups post-treatment 0.024. PSSE group difference, we had a mean reduction minus 2.88 plus minus 5.63 degree. And as we saw here, there was no statistical significant difference in co-bangle in general exercises group within groups. We had a p-value 0.10. And the progression, we had the progression in general group that is plus 0.75 degree, plus minus 5.69 degree. PSSE short group showed superior outcomes in co-bangle. That was significant improvements in 60% of the patients remained stable. As I told you before, remaining stable in this particular age is good, is a good result. And for 26.77% showed improvement of the patients, and only 13.33% worsened with the PSSE. In the contrary, in the control group, we had 20.01% remain stable, 6.67% improved, and 73.3% worsened. So that we suggest in this case that PSSE short therapy offer greater results in co-bangle during the 6 months of the treatment. Here are our results in graphic. So we had a lot of worsened patients in the general exercises group with the exercises that we told before. PSSE short group showed greater co-bangle improvement after the 6 months of treatment for 86.77%. So we did together improvement and stop the progression. And general exercises group showed deterioration of 73.3% of the group. Our findings of the study align with previous study that told us that we had better results with the PSSE exercises that are focused on 3D correction. We had some limitation in this study. The sample size, while adequate, remained moderate, only 30 patients. And long-term outcomes beyond 6 months were not assessed. And adherence to home exercises, because we give them exercises program at home. We need to encourage and monitor may vary across individuals and influence outcomes. Future study might benefit from incorporating wearable technology to objective track engagement and expand follow-up to evaluate. And another outcome is bracing needs and psychological trajectories over time that need tracks. As a conclusion, physiotherapy scoliosis specific exercises, shrub therapy is more effective than general exercises in improving co-bangle in adolescents with idiopathic scoliosis. The improvement in co-bangle highlight the clinical value of curve-specific, posture corrective, and breathing-focused exercises. These findings should encourage clinicians to advocate the wide access to structured scoliosis-specific programs in both outpatients and school-based rehabilitation setting. Thank you very much for your attention. I'm here to ask you any question, and I will write here my mail if you have any question to write me. Thank you.
Yes. This is the presentation from Dr. Hello. Yes, please let me know if you have any questions regarding this topic.
Yes.
So there is no questions, madam. If anybody is having any kind of questions regarding this topic, you can text us so that we can ask behalf of you even after the completion of the congress. Thank you so much, madam. It was a great presentation. I will be getting the participation certificate and the
Thank you.
booklet within a couple of days. Thank you once again.
Thank you.
Yes. Next speaker, we go with Dr. Adam Hamu from University of Washington School of Medicine from Dulce Hospital to start presenting. Dr. Adam Hamu.
All right. Can everybody see my presentation here?
Yes, sir. It's perfect.
Okay.
Yes, sir.
All right. Let's get started. Hello, everybody. It's a pleasure to be here. My name's Adam Armour. I'm a third-year medical student with the University of Washington. This study that I'm going to talk to you about today is in partnership with Dulce Hospital in Nepal and Kathmandu University School of Medical Studies. So let's talk about physical therapy, rehabilitation, cardiac rehab in Nepal. So the title of the study is Implementation of a Physiotherapy Program over Telemedicine for Cardiac Patients in Rural Nepal. I'd like to acknowledge my co-authors here, Mrs. Sabarna Chetri, who's the PI for this project, and Ms. Roshni Shrestha. Okay, so before I go into the details of the study, I just want to get a background for you of Nepal. So it borders China to the north and India to the south. It has roughly 30 million people, and the majority of the population is in urban centers, about 65%, but 35% of the population is in rural centers. And a lot of it is in the middle region of Nepal, which is the hill region. And so communities are kind of scattered between valleys and spurs and can be kind of hard to reach. So Dulakel Hospital, which is where I was at, is 30 kilometers southeast of the capital of Kathmandu. And as you can see here, Kathmandu is kind of in the central eastern portion of Nepal. The Dulakel Hospital is pretty unique. It was established in 1996 by Dr. Ram, who's a general surgeon. He's still the CEO and director there. And he had this unique idea of how to reach out to patients that are geographically isolated in communities around the area that typically wouldn't be able to get access to care. So it's kind of hard to see on this map, but if you can see these points of interest markers that are scattered around here, these are outreach centers that he established surrounding the area. They're affiliated with the hospital, and they're staffed with rotating members, physicians, nursing staff, ancillary staff. And what they do is essentially triage patients. Patients will show up to them with an acute problem, and if they can't take care of it there, then they'll either directly send them to the hospital or they'll establish an appointment with the hospital and the patient will provide their own transportation. So because of these outreach centers scattered around, the hospital is able to service a very large population of 2.5 million people, which is 8% of the population. One of the problems there is that the nearest outreach center is 30 minutes away, but the farthest outreach center is 7 hours away by bus or car. So pretty far removed from the hospital itself. That's one thing to keep in mind. And one last thing about for the background of the country that I want to leave you with is they're working towards universal health care. In 2016, they established a national health insurance program where Nepalese citizens have the option to pay an annual fee, and then their healthcare costs will be taken care of by the state. And it's grown over time. It started with not a lot of districts participating, and now roughly 60 to 70% of the population is enrolled in the program, which is good, and that's a lot of progress. But that also leaves about 30 to 40% of the population without insurance. And part of it is they may not know about the program or they can't afford the annual fees for it. In addition to that, even if patients are enrolled in the program, they still have to pay 20% of all out-of-pocket costs. So that's every cost incurred. That's pharmacy, provider costs, any imaging, 20% of all of that. So there's something to keep in mind as we're talking about why we're doing this study. So from 1990 to 2020, the average life expectancy for a Nepalese citizen went from 54 to 70, and the cause of death kind of transitioned from acute trauma and infection to chronic disease, which is now the leading cause. A specific cardiac disease. In a study they did in 2016, 27% of the population died from cardiac disease in 2016. So this is the biggest chronic disease that Nepal is facing. They've tried some preventative measures, the Ministry of Health, to address these problems, things like lifestyle and behavior modification, tobacco cessation, diet modification, etc. But when they do large-scale studies of that, the efficacy they find is only about 2 to 20%. So, and that depends on what they're trying to modify and how involved the providers are with the patient. So it's not an effective way to tackle the burden of disease that cardiac disease plays for those patients. One of the ways that Dulakel Hospital attempted to tackle this was establishing a cardiac rehabilitation program in 2020, an inpatient cardiac rehab program. So for anybody that's unfamiliar with it, I know most people probably are familiar with it, but I'll briefly talk about what a cardiac rehab program is. The standard of care in high resource regions is when a patient has an acute cardiac event like heart failure or a heart attack, they'll get assigned a cardiologist and a dietitian. They'll get education and counseling, and then they'll get inpatient physical therapy services. And they'll come into the hospital 2 to 3 times a week where they're monitored by physical therapists, and they'll get put through increasingly more intense exercises. And over 20 weeks, this program is done. It's meant to stabilize symptoms. It's meant to prevent reembolization, rehospitalization, and it's pretty effective. So that's the standard of care in high resource regions. In Nepal, they have access to cardiologists and physiotherapists, but they don't have access to a lot of the counseling services and dietitians that are part of the standard of care in other regions. So the burden for cardiac rehabilitation falls on the physiotherapists. But one of the reasons that we're trying to make it work so well, because the research shows that it's effective. So systematic review shows that cardiac rehabilitation is associated with 25% less cardiac mortality, 18% less hospitalizations, and increased quality of life. And quite a bit of stuff in addition to that that's not listed, like better adherence to medication regimen, more stable symptoms, things like that. Interestingly enough, other systematic reviews, international systematic reviews, found that those outcomes are preserved over telemedicine. So the results that you get in an inpatient physiotherapy rehab program, you can get with a telemedicine program as long as it's set up well. And the two major factors of success for that are supervised sessions and personalized sessions. So supervised meaning it's one-on-one with a physiotherapist, or as low to one-on-one as you can get. And two, that it's not a cookie cutter approach. The program is built for each patient given their current symptomology and their progress. Those are the two biggest factors for a successful telemedicine cardiac rehab program, as per systematic reviews. So the reason we're trying to do a telemedicine program in Nepal is because the inpatient program that's been running since 2020, unfortunately, has been ineffective. Of the patients that are eligible, less than 25% enroll, and of those that enrolled, we haven't quantified it formally. It's kind of hard with the record system we have, but probably 5 to 15% of patients attend more than half the sessions. So even though it's shown to be an effective intervention, it's not being followed through enough by patients to really make a difference in the burden of disease. So two reasons we've identified for that, the main reasons we've identified for that, is geographical isolation and cost. So if you can see to the right here, the situation of some of the roads, these are what most roads look like 5 minutes outside of any major urban area. And they're dangerous to travel on in the summertime during monsoon season. When I was there in the summer 2024, I've been there for about 2 weeks, and unfortunately, there was an accident where 2 buses and 70 people passed away. And this is not an isolated incident; it happens every year. So the travel conditions aren't great, and not a lot of people do have transportation in the first place. And then the cost, once again, patients, even if they are enrolled in the health insurance program, incur 20% of all medical costs. And inpatient services are more expensive than a telemedicine service. So it racks up over time if they're coming to the hospital 2 to 3 times a week for rehabilitation. Interestingly enough, although the road system may not be that good, most patients have access to a phone, a computer, and Wi-Fi. So a phone with a camera and Wi-Fi. So even though they're not physically connected, they may be digitally connected. And that's why we went into this project thinking that telemedicine would be the solution. So the design of the study is what we'll talk about next. This is an implementation science study. For anybody unfamiliar, implementation science is taking an idea that we already know works. We're not proving that cardiac rehabilitation works. We're not doing a randomized controlled trial. A lot of the data out there already shows that it works. So we're taking effective interventions and we're applying them systematically to an organization, and we're measuring outcomes while we do it. And measuring those outcomes to see, are we successfully getting the results we want? So that's what this study design is. The populations that we're assessing are patients with heart failure and patients with ischemic heart disease or coronary disease. And here's what we're measuring. We're measuring exercise tolerance. The main way we're assessing this, we don't have access to VO2 assessment, VO2 max assessment easily, but things like 1 minute sit to stand, 6-minute walk, things like that we're using to evaluate exercise tolerance. We're using the WHO's quality of life survey to assess quality of life. And then some clinical markers are being measured as well, like blood pressure, ejection fraction, body mass index. So that's what we're measuring over the course of patient start to patient in the program. The program is about 20 weeks long. It's in 3 phases. So the first phase is when the patient is admitted to the hospital with a cardiac event, either acute decompensated heart failure or an MI, heart attack. And during this time, it's about 3 to 7 days. The physiotherapist talks with the patient and their family if they're interested and they enroll in the program. And then they measure their baseline activity, fatigability, range of motion, and they do that a couple times a day. During this time, they're risk stratifying the patient, low, medium, high risk, based on their symptomology and where they're currently at. And they're using that to help design the program for them moving forward. So the physical therapist that approached them at bedside during this admission phase is the physical therapist that stays with them and does telemedicine rehab with them for the next 2 phases. So phase 2 is when they go home, they're discharged from the hospital. It's about 6 to 8 weeks, and it's a low intensity program. So they do shorter sessions, 20 to 40 minutes, 3 to 5 times a week. And they're slowly building over time with these sessions based on how they're improving and based on the physiotherapist recommendations. So after this phase, they come back into the hospital. They meet with their cardiologist again. He looks at their medications, medication adherence. We review their blood pressure, BMI, lipid profile. The physiotherapist talks with them, assesses them, and then they go back home, and we move on to the final phase, which is a higher, moderate to high intensity program. 5 to 12 weeks, depending on how the patient's progressing. And these are less frequent but more intense sessions, 30 to 60 minutes with the physiotherapist. And eventually, the patient gets to a point where they graduate from the program. The physiotherapist thinks that they're doing these exercises well on their own. There's not much more the physiotherapist can add, and then they're complete. And so at this point in time, they'll come back into the hospital, and for the final time, we'll remeasure all of these outcomes. So they'll get their 1 minute sit to stand analyzed. They'll fill out the quality of life survey again. They'll get that analyzed, and they'll get a formal echocardiogram and have that assessed as well with other clinical markers after the 3rd phase. So the cool thing about implementation science is we already know what works. So we're allowed to change it as the study is ongoing, because the point is that you achieve the results you want to achieve. So in order to do that, this is being established in a block design. So we're looking to do 90 patients total. And by the way, we've done a couple pilot studies so far with a couple cohorts of patients. But currently the study's waiting for ethical approval, IRB approval. So it's ongoing. But we're looking for about 90 patients. We're going to divide them into 3 blocks of 30. We'll start with the first block, and after 6 weeks, we'll analyze how's our patient adherence, compliance, what are issues that we're having, what are things we need to change, and then we'll implement that for the next blocks. And the goal, hopefully by the end of that, is to have a well-functioning program. So we'll do analysis after all 90 patients, and then we'll recommend to the hospital, hey, this is working a lot. We recommend this be a policy change where we're not doing inpatient cardiac rehab anymore. We just are going to do telemedicine rehab because it's a lot more adherent for patients. Or maybe it fails and it doesn't work, and we'll let the hospital know, hey, this is not feasible at this time. And we're also thinking, if this is effective for physical therapy, there's several other avenues it could be effective for. So that's kind of the end goal of making this so formal. So I don't want to spend a whole lot of time on this, but essentially what we're looking for, parameters for success, is if more than 50% of the patients are eligible and attend more than a third of the sessions. It doesn't sound optimal given those numbers, but that's the standard of care internationally, and that's a lot higher than our current numbers. So that's what we're aiming for. And if we have lower enrollment and adherence than that, we might look at the program and say it's not feasible at this time, given whatever limitation. So with the cohorts that we found so far, here's some of the limitations we've discovered. For one, it's dependent upon technology. So if a patient doesn't have access to a phone with a camera or a computer with a camera and Wi-Fi, they can't participate in the study. Also, we're limited on resources at the home, right? So normally if a patient comes into the hospital, they can use an exercise bike and a treadmill and weights and other things like that. But at the home, the physiotherapists have to be pretty creative in coming up with a program for them to use. So that's one of the limitations we've discovered. Another is a huge resource limiting factor is the personnel. Even though there are a lot of really well-trained physiotherapists at Dulick Health Hospital, they've got a lot of other competing priorities, and doing this on top of that has been challenging. And then scheduling conflicts, of course. We don't have the reliance of computer systems that will auto-remind patients via text that they have an appointment or something like that. It's all done on paper, and it's all up to the patient and the provider to remember. And so that's something we're also working through and has been a limitation for us. But with that is all I have for you. I'd just like to acknowledge thanks to Dulick Hospital, Kathmandu University School of Medical Sciences, and the patients of Kavra-Palanchok and surrounding districts, and my wonderful team here. And here's my email if anybody has any questions. But that's my talk. Thank you.
Yes. Any questions regarding this topic to Dr. Adam Mahmood? Any? I think there's no questions, sir. Thank you so much, sir, for once again for participation in this congress. Hope we expect your presence for next year in face-to-face meeting. And you'll be getting the participation certificate and the booklet within a couple of days. Thank you once again.
Thank you.
Yes. If you are if you're having any kind of questions regarding this topic, you can text us or you can mail us officially to our conference email ID so that we can forward this all the queries to the concerned speaker for this conference. Thank you once again. Yes, so next speaker, we request Dr. Amira Dahid from Department of Physical Therapy from the IFA Academic College. The topic will be the impact of clinical training on report low back pain among hospitalized nursing students, a comparative cross-section study.
Okay.
Yes, it's fine.
Good morning.
Yes.
My name is Amir Odaher. I'm a physical therapist, and I'm a staff of Safed Academic College in Safed. This is a study that I've made with my friend about nursing students who are in hospital-based clinical training, and we want to determine the low back pain among the students when they were in hospital-based clinical training, and how is this clinical training affect their back pain. Some backgrounds. Low back pain is a global public health issue. It affects about 577 million people, second most common health condition worldwide. Nurses are especially vulnerable due to physical job demands for low back pain. Why low back pain is well documented in healthcare professionals, its onset and progression during nursing student clinical training remain unclear, and this is why we want to investigate this issue. Okay, students are exposed early to physical demanding tasks, often with lack of ergonomic training. This put them in a risk for developing low back pain even before they were begin full-time job work. The aim of the study to investigate prevalence, risk factors, predictors, and impact of low back pain among nursing students during hospital-based clinical training. The study design was a cross-sectional study, online study. We conducted it between August 2023 to August 2024. 194 third and fourth year nursing students in hospitals in North Districts in Galilee. Excuse me a moment. A moment, please. Okay. Measures disability. We measure disability with Oswestry Disability Index questionnaire. Pain intensity, we measured it with the Visual Analog Scale, VAS. We also have a questionnaire for sociodemographic questionnaire. Perceived stress scale index. We investigated clinical stress, family stress, personal stress, social domains, and we want to investigate whether this stress affected the low back pain, lifestyle, physical activity, BMI, smoking, and etc. Some key definitions. When we said low back pain, we mean pain between lower limbs and hips. The Oswestry Disability Index, it's a questionnaire that participants rated 10 items on a 5-point scale from 0, no pain, to 5, worst pain imaginable, with the maximum score for the questionnaire is 50. Higher score indicate greater disability. Scores more and equal to 12 were deemed to indicate low back pain with disability, whereas scores less than 12 were deemed to indicate lower back pain without disability. The sociodemographic, about 65% of the students were female, mean age about 26, 75% of them were single, 72% of them were physically active. BMI was within healthy range. Low back pain prevalence over time. Before nursing school, 30% of the students reported low back pain. At the last year, 54% of the students, 0.6 reported low back pain. And in the last month, during training students, clinical training means 75% of the students reported low back pain. How pain-related hospitalization. Some students were hospitalized because of their low back pain. 8% of them had been hospitalized due to low back pain in the last year. All hospital students were in their 4th year. This was also interesting. 66% of the students reported increased low back pain with more hospitals rotations. 22% of the students use painkillers during clinical training. About 30% of them, of this 22%, often took painkillers daily. The stress index. The highest level of stress means to a very large extent was most frequently associated with clinical training. 26 of the students said that they reported they have clinical training stress. 15% of them personal stress, 12% of reported family stress, and 9.8, about 10% of them reported social life stress. Stress and low back pain. Clinical training stress was significantly associated with low back pain in the past months, clinical training. Low back pain was more common in students with high clinical stress, about 80% of them, than in those without stress, 45% of them. Stress was positively correlated with intensity of pain, the VAS index, the Visual Analog Scale questionnaire. Predictors for low back pain disability mean OSWAS-3 index more or equal to 12. Students who report a clinical stress, the odds ratio for reporting low back pain was 1.7. Student with pain in the neck and shoulder, the odds ratio was 3, means 3 more times they were reported low back pain. Marital status, being married, also the odds ratio was also about 3. Non-significant predictors. It was surprising that age, gender, physical activity, and smoking were not significant predictors for low back pain. Discussions and highlights. A hospital clinical training increased low back pain risk. Psychological clinical stress contributed to low back pain. Period musculoskeletal pain increased vulnerability of low back pain. Protective factors, being single. It's interesting, being single, lower risk for low back pain, possibly because fewer family duties and stress of married couples. Limitation. The sample size was not so big, not so large, 194. It is self-reporting questionnaire, so maybe it could be a bias possible. There was no follow-up, so we can't assess progression over time. A practical recommendation. We recommended to embedded mandatory ergonomic training into nursing curriculum, integrate stress management for students, routinely conduct musculoskeletal health screening students that they have neck pain, low back pain before starting studying, so that they can, if we screen them in the first, maybe we can help them not to develop low back pain. Curriculum implications. Provides hands-on safe lifting workshops, encourage use assistive devices, and refuse to unsafe manual lifting tasks during training, because students maybe they have not the courage to refuse for unsafe demands. So we should encourage them to do it. Long-term goals. Improve self-health, improve student health, reduce low back pain related dropout, support resilient nursing workforce. Future studies. Future studies should be longitudinal study, tracking of low back pain progression. Evaluate the impact of the intervention program on reducing low back pain among nursing students. A final conclusion. Low back pain is highly prevalent and worsened during clinical training. It is not just a physical issue, it's also psychological and functional. If we want to support resilient and healthy nursing workforce, we must act early in this with nursing students. Thank you for listening.
Thank you so much, Madam. It was a nice presentation. Yes, any questions regarding this topic? Any questions?
Thank you for listening.
Yes, unfortunately, you are missing the in-person participation by as yesterday's conference. Hope we expect your presence for Dubai conference as well.
Thank you.
Thank you so much once again. And you will be getting the participation certificate and booklet within a couple of days. Thank you so much. So the next keynote speaker of the day, Dr. Silvio Di Rocco from Imperial International School, Director from Switzerland. The title of the clinical posturometry for diagnosis, treatment planning, and follow-up in health sciences. Yes, sir, you can start presenting.
Okay, thank you so much for your invitation. I am here again. I will try to share the presentation. Let me 1 second. I think you see now the presentation. You confirm me? Yes, you see
Yes,
the
yes.
presentation. Yes.
Yes.
Okay. Okay. Today I will try to talk about something who is, I think, very important. And it's always important. It's a pleasure for me to be part of this meeting. Anytime you invite me, I am here. But duty, because in my school I am very, very busy. It was not possible. And we have a very big difference. I am in Spain now, and I have a very, very different timetable. But I am here. Always I am here. It's a very nice meeting. It's a very nice conference. Okay, and let me start because today I will introduce for the people who don't know that an innovative tool who is the posturometer. It's an instrument for diagnosis and treatment for all medical sciences. The aim of today is to give a little brief regarding how it is useful, the posturometer, an objective instrument, mainly in this case for physiotherapists and sports also. And let me go introduce officially in this fascinating world of clinical posturometry. I think it's a fascinating world. This field allow us to observe the patient in a different way, to make a diagnosis, to plan a treatment, and to have control of the treatment. In our school, we introduced the posturometer many, many years ago. It was about 40 years ago. I was dealing with that instrument, and it's a very interesting tool for all medical science. But today I was talking about physiotherapists. And at that time, and this guy, Galileo Galilei, I think you know very well who he was. He cannot prove that the Earth was not the center of the universe. He has to stay with the mouth shut and say, yes, okay, you are right. Today we can measure. Today we can prove different things. And I think the posturometer is an instrument who will transform the clinical opinion into science. And that is very important, I think. Posturometer is helpful and I think is indispensable for all medical sciences, for diagnosis, plan treatment, mainly to follow the treatment, to see if you are going well or not. And that's very important, I think, in the medical sciences. I will try to shortly explain the concepts of posturometry, because posturometry is a medical science, very, very complicated. But in a short time, I try to inform all of you the concept of the posturometry. Posturometer is an objective instrument. And when we measure with something that is objective and with a special protocol, because many, many years ago, I created a protocol to evaluate the graphs and the trace and to do a clinical diagnosis. And I think that is very important. Let me define what is posturometry. Posturometry is a diagnostic test that is in medical sciences. It's something that we study in the universities. Includes different parameters to measure, but here we are dealing, this posturometer we use in the whole medical science, even a dentist, a pedestrian, a medical doctor. But today we were talking about physical rehabilitation, and we can analyze how is the posture just to have the priority for where we have to start. And I think this is very, very important. The most important contribution is allow us not just to observe function. And you know, as a physiotherapist, all of you know very well, at sometimes the treatment relieves, and we don't understand why. And sometimes we change techniques, we change point of view, etc., etc. But I think when you go and you analyze the things that are disturbing the posture, we call that the tonic postural system. And you physio deal every day with this tonic postural system. Measuring what? We measure the receptors. Main receptors in the tonic postural systems are the oculomotor system, movement, vision, the foot support, mainly. We have a lot of receptors. And we have a big disturber for the whole tonical postural system with the craniofacial system that mainly we confuse with TMJs. TMJs is part of the craniofacial system, it's part. It's not just TMJs. And when that system is working bad, we said is under dysfunction. That is creating a lot of problem at the muscle change. And you work every day with muscle change. Imagine if you have a system who is disturbing every single moment of the life is disturbing the posture. How you can do rehabilitation? How you can deal with athletes? The oculomotor system, the craniofacial system. This patient is a particular patient. We see this patient every day, every single day. Oculomotor system problem, postural problem, foot support, mouth support. How we work? Who start? Start first the dentist, start first the physiotherapist, the osteopaths. If you measure and you understand what is the main perturber, the main disturber of the posture, you can go following a plan of treatment. MPR, myofunctional postural rehabilitation, is a protocol that I invented 40 years ago that followed that protocol. But when you measure, you understand. If it's not, it's just observation. That's why in our school we said clinical observation is good, measure, you complete. You are doing science, your clinical opinion. Another patient. Every day we see this kind of patient. This patient have a shorter leg, have mouse problem. How we work? You cannot apply a rehabilitation only if you understand the body is connected. You cannot understand, if you understand the body is connected, you cannot work alone. And if you want to work in interdisciplinary concept, you have to speak the same language, because if it's not, we cannot understand each other. And the posturometer is a good tool. I call it's like a sheep that connect the different specialities. Today I cannot explain how it works, but just to give the concept. What we measure the receptors, the proprioception, to see if they are working well or not, and to observe what are they doing with the tonic postural system. I show you the structure of the posturometer. The posturometer is based in the concept of Capanghi, and I think you know very well Capanghi, physiotherapists know very well, to study how is the body weight distributed into the floor in 3 points. This posturometer have 3 sensors which take in this area, send into the computer software analyze, and we have a protocol to make the interpretation. If it's not, it's just an instrument. You need a clinical protocol to work with the posturometer. You know very well how Capanghi studied the foot distribution, 3 points, first metatarsus, fifth metatarsus calcaneus. You have a triangle there. The center of the triangle is the very center of the foot. This posturometer takes the information, send the information to the computer, and you can analyze what happened with the body. 3 exams, very simple, 10 seconds each exam. The first one is mouth open, eyes open. We are testing the posture of this patient today. Second exam, we keep the eyes open, we close the mouth, and we measure. Another 10 seconds, and we will see the effect of the craniofacial system into the posture. And then we open the mouth, close the eyes, and we can study the foot support. 3 simple exams. And obviously, with the diagnosis protocol, you can have the diagnosis in 30 seconds. The posturometer sends information, give a graph like this, yes? Very simple to observe. You see that you don't know posturometer, you can understand triangles of the area of Capanghi. You can see how is working that. First metatarsus, fifth metatarsus calcaneus, red, dangerous, yellow, attention, green, normal. The point up, the point down, more, and left charge. If you have a protocol to understand that, study posturometry, you can arrive at a good diagnosis. You can see also the overload, right or left. And you can see the effect. You can measure more than that, but today I don't have much time to do that, to show that, perhaps. We have green, yellow, and red, like a traffic light. And look at here, 2 different graphs. We have here we measure the effect of the mouth. And you see what happened, mouth open, mouth closed, how the graph change. This is a proof that the craniofacial system is disturbing the posture. And how you work with a system like this, who is disturbing every 5 seconds of your life, the muscle change. Very difficult to work like this. Barycenter, you can study the barycenter, you can study the position of the barycenter. Through the barycenter, you study also other things, muscle activity, etc., etc. You can study the foot support, you can study a lot of things. But I want to show you shortly a clinical case, just to all of you can understand what happened. This is a patient who have a real short leg. That means an anatomical problem. Has also problem in the craniofacial system, a little lateral deviation. And you will observe the protocol we apply and how you can measure if you are good or not, because sometimes we don't know if we are going to the correct way. We can make a mistake. We are human. We are not God. You can make a mistake. If you measure, you know immediately if you are going well or wrong. And this is the patient. We have a real short leg, lateral deviation, bad occlusion, who is creating problem into the posture. And here, how is changing the two graph, and how the two graph are changing. Mouse open, mouse closed, and how is overloading. Imagine anytime closing during the night time, because during the day you are not with the teeth touching, but during the night the brain is memorizing this bad situation and starting bruxisms. To correct the situation is creating more chaos. And this is another topic. It's very difficult to explain here how it's working, but every single day overloading must change how you work as a physio. You cannot. And look at here. We apply, we do simple treatment. We identify that the craniofacial system disturbed. We annulate the craniofacial system with a simple device, call it BED device, body equilibrium device. It's a device who use all medical sciences, physiotherapists, doctors. You don't need, it's not necessary you to be a dentist to use this plastic device. You annulate, you have to be trained, obviously. You annulate, we annulate the craniofacial system. We put a little insult to correct the anatomical problem, physiotherapy, osteopathy, and that's the result. If you go here, you see the graph, all red, just not understanding posturometry, colors, all attention, here, all green, and no overload. But we measure, we understood, and we work together. This is comparison. And now, how it works in the sport, athletes, because I think that is important also. Athletes, you know very well, when athletes have dysfunctions, the performance is less. And also there, posturology, posturometry, craniofacial system, and more things. But when you go, this is a research I did many, many years ago in Switzerland. We measure the alteration of the athletes. We individuate that craniofacial system was disturbing. We measure for that. Then we said, okay, you go and you do an exercises. The best way to do that quick is force, weight. And we said to these athletes, go ahead. How is the maximum you can put up? Imagine 100 kilos, 120 kilos. All right, that's okay. Don't relax, because if you relax, that is not valid. We put the bed device, repeat, annulating that before we measure it, that the bed was working well. No, put the bed device, put 25% more kilos. Proof that the performance is disturbing also, not only for the craniofacial system, but if you don't measure what is the disturb, you are not sure what is the primary situation. We measure better. Bed, body. I call that, I invented that device 25 years ago for all medical sciences. It's a plastic device, but I call it body equilibrium device. Why? Because it's that. It's a device to do the equilibrium of the body. Another, the exercises, and another athlete with the same problem. We did a research, I don't remember exactly, but it was more than 100 athletes. And this is the short proof that why we arrive to that situation, that information, all right? This guy, weight is easy because you know how immediately you know that. It's very easy to prove it. Different exercises. Here, if you see the mouse, the athlete had the mouse with the bed in place just to do and repeat it. Okay. Injuries. Athletes have injuries. And sometimes injuries is imbalance in the craniofacial system, tonic postural system, foot support. You can individuate, you annulate that, injuries is less. You know that guy, eh? Look at before treatment, after treatment. Now it's championship. When he was younger, look at the head, torsion. These were not good. Treatment, rehabilitation, and now he's this. I don't treat it. It was another, but just to show. Here, Federer also is perfect balance. That one. Compare the both. You compare the both. Mouse, eyes. This guy, Nadal, a lot of injuries. Less injuries, Federer. And we can go ahead. A lot of athletes. Look at here. Ronaldinho, a lot. Look at the mouse. Look at the body posture was terrible. Injuries. Another champion, Ronaldo, many, many years ago. And that was perfect. Pelé, many years ago, was a perfect balance. A perfect balance. And that's important also in athlete to measure, individuate, and treat. And that's very, very important. And thank you so much. A very short presentation. I don't want to take time for another guys to present. This is the thing. Here is all my contacts. This is our application. In our application is a free application. You can enter there and you can see a lot of things we do in our school. And thank you so much. Thank you so much for the invitation. I am so sorry we cannot meet together. Anytime you do a meeting, I am busy abroad. Maybe next year we will be there, and we can do a practical demonstration. Thank you so much for your invitation. I'm very, very happy to be here. You are a very nice organization in the meeting in your congress. Thank you so much.
Thank you so much, sir. Hope we expect your presence next year for at least a face-to-face meeting for 2026.
Thank you so much. Thank you very much.
Yes, thank you so much, sir. Have a nice day, sir. Bye. You'll be getting the participation certificate and booklet within a couple of days. Thank you so much.
You so much.
So next speaker, we would like to invite Dr. Paula de Cruz Pence from Brazil, the Department of Physiotherapy, University Federal of Minas. If you are not present in the Zoom meeting, we have request you to go with the alternate speaker. That is Dr. Thomas Volny from Institute of Physiotherapy and Health Sciences from Jerzy Pukozio Academy of Physical Education from Poland. Yes, sir. You can start. You can start presenting, doctor. Only. We request Dr. Thomas to start the presentation if you are ready with your PowerPoint presentation.
Hello, do you hear me? Hello, do you hear me? Hello, I don't know if you are hear me. Okay, I don't know if you are hear me, but
Yes, sir.
yes, thank you very much. Okay, good morning. I would like to present to you the results of my research on cubital tunnel syndrome. The topic of my presentation today is the neurodynamic technique versus shame therapy in the treatment of cubital tunnel syndrome, randomized placebo-controlled trial. Yes, if you of course know cubital tunnel syndrome is the second most common peripheral neuropathy of the upper limb with a prevalence ranging from 2 to 6%. Initial symptoms include paresthesis and mild hypothesis of the 5 and 4 finger and related to the position of the elbow. Over time, motor dysfunction develops, manifesting as a weakness and atrophy of the intrinsic muscle of the hand. This progression can significantly impair hand function related to both activities of daily living and work, leading to progressive disability and reducing health-related quality of life. Given its high prevalence, cubital tunnel syndrome is a major medical, economic, and social challenge. The management of cubital tunnel syndrome include both conservative and surgical approaches. Conservative treatment is usually recommended as the first-line therapy. This treatment includes the modification of activities, orthoses, non-steroid drugs, local steroid injection, and physiotherapy approaches. However, as noted by Mesian, the conservative treatment of the cubital tunnel syndrome relies more on the therapist's empirical experience than high quality scientific evidence. Physiotherapy appears to be one of the first form of the conservative treatment of cubital tunnel syndrome. To date, one systematic review and one critical review of the literature have shown the effectiveness of physiotherapy in the treatment of cubital tunnel syndrome. The authors emphasize that there are a small number of randomized clinical trials evaluating the effectiveness of physiotherapy in the treatment of cubital tunnel syndrome, and it is difficult to conclusively determine the efficacy of specific intervention. Three randomized clinical trials and three case studies evaluating the effectiveness of neurodynamic technique. While these studies reported beneficial therapeutic effects, neurodynamic technique were only one component of the therapeutic programs. This does not clearly indicate the neurodynamic technique are effective in cubital tunnel syndrome. Therefore, the aim of this study is to evaluate the effectiveness of neurodynamic technique compared to shame therapy in the physiotherapy management of cubital tunnel syndrome. The Bioethics Committee for Scientific Studies at the Academy of Physical Education in Katowice authorized the study. The study was designed as a single blinded randomized placebo-controlled trial. People diagnosed with cubital tunnel syndrome, initially 136 people, of whom 91 complete the full protocol. Each patient who met the inclusion criteria was enrolled in the study and randomly assigned to one of two parallel groups, neurodynamic technique and shame therapy using a computer random number. Individuals with cubital tunnel syndrome were blinded to the therapy they received. Clinical test, McGowan classification, elbow flexion test, Tinel sign. Primary outcome was nerve conduction study, ultrasound imaging, cross-section area and shear modulus, and pain using the numerical pain rating scale. Secondary outcomes, 2-point discrimination sensation, cutaneous sensation, sensory perception, threshold, symptoms and ability to perform certain activities, changes of improvement after treatment. In the neurodynamic technique group, manual therapy was based on sliding and tensioning neurodynamic techniques of the ulnar nerve. In the shame therapy, placebo therapy, shame manual therapy was based on shame sliding and the shame tensioning neurodynamic technique of the ulnar nerve. Standard protocol include 60 repetition of the sliding and tensioning distal and proximal neurodynamic technique, separating by interseries interventional of 50 seconds 5 times a week for 10 sessions. Shame neurodynamic technique were performed without using the neurodynamic sequence. A baseline assessment, when we talk about the clinical tests, a baseline assessment revealed no differences in all examined parameters. A final assessment reveals statistically significant intergroup differences in all clinical tests. The same we can see in the primary outcomes. A baseline assessment revealed no intergroup differences in all examined parameters. A final assessment revealed statistically significant intergroup differences in all primary outcomes. The same was in the secondary outcomes. A baseline assessment revealed no intergroup differences in all examined parameters, and final assessment revealed reveals statistically significant intergroup differences in all secondary outcomes. The findings demonstrate that neurodynamic techniques have beneficial therapeutic effects as evidenced by improvement in objective measurements such as nerve conduction, ultrasound measurement, provocation test, discriminative sensation, and sensory threshold. And the subjective assessment of individuals with cubital tunnel syndrome include the degree of upper limb disability and neuropathic pain, indicates a beneficial effect of neurodynamic technique compared to shame therapy. To our knowledge, this study is the first to evaluate the effectiveness of a neurodynamic technique used as the only therapeutic tool in the treatment of mild to moderate forms of cubital tunnel syndrome. Studies conducted so far have not clearly demonstrated the beneficial effect of neurodynamic technique in the treatment of cubital tunnel syndrome. Therefore, we recommend that the use of a neurodynamic technique in the conservative treatment of cubital tunnel syndrome. The main limitation, of course, of this study is the lack of double-blind design. Individuals with cubital tunnel syndrome were blinded to the therapy they received, but the physiotherapists were fully aware of the therapy they administered. Another limitation is the lack of assessment of the long-term effects of the therapy. Unfortunately, such a study would be unethical. Conclusions. The use of neurodynamic technique in the conservative treatment of individuals with cubital tunnel syndrome is more effective than shame therapy. Significant improvements were obtained both in the objective parameters and in the subjective syndrome. Thank you for your attention.
So this was a presentation from Dr. Thomas. Any questions regarding this topic?
Can I take the floor?
Yes, madam, go ahead.
Okay, hello, Dr. Thomas. Is there any way we can get in touch with you? Your email address?
Yes, yes,
yes, of course. Yes, of course. I email. I do make my email in the chat.
Yeah. Have you had any patients in regards to cubital tunnel syndrome after surgery? Have you handled one or?
Yes, yes, but of course, in my study, I work only with patients without the surgery. Yes.
Okay. Is there any specific upper tension test? I mean, exercises that you? I'm not sure if you have included it in this presentation, like what particular specific upper tension limb test, something like that.
Sorry, I sent the email. Could you repeat the question?
So one of your interventions was the upper limb tension. It's like
Yes.
Is there, because I'm aware of the, what is number 1, 2, 3, or 4. Is there any, I would like to know what specific limb tension that you have included in your intervention.
Yes, I did two intervention. One standard cubital, no, one standard therapy with the flexion elbow and one special therapy with extended elbow, because we know the most important is to have extend elbow, yes, in the treatment of the cubital tunnel syndrome.
So I'm thinking kindly accept or refute, validate it, sir. Doc, if you are saying about the bias and without bias when you do the limb extension.
Yes, it is the special modification of the ulnar nerve therapy. Yes, of course, I can write to you. You have my email, and if you would like to know how I did it, I of course can write to you and show the second part of the therapy.
Thank you, Dr. Thomas. I'm looking forward to get in
Okay,
touch
thank you
with
very much.
Yes. So if you have any further questions regarding this topic, you want text us in email. So we can ask behalf of you even after that counters. Thank you so much, sir. It was a nice presentation. You'll be getting the participation certificate and booklet within a couple of days. Thank you. We are having one more talk for this today's conference. That is Dr. Gustavo Pereira from Korea, from web study, Barcelona, Portuguese, are supposed to present. So we are supposed to wait up more half an hour. And meanwhile, we can take for 10 minutes of break and rejoin again.
Hello. Acho que o microfone não vai funcionar. Hello. Fecha a janela. Hello. Hello, good afternoon.
Hello. Hello, good afternoon. Entendi. Tô vendo aqui, mas acho que ninguém tá me ouvindo. Tá vendo? Tô aqui na reunião, mas ninguém tá aqui. Hello, good afternoon. Can everybody listen to me? Tô entendendo isso. Hello. 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 Já tá no máximo. Não, aqui ninguém responde. Seria outra pessoa? Sim. Hello. Can everybody listen? Hello?
Yes, Gustavo, Sammy. Start your
Oh. So can people listen to me?
Yes, we are.
Oh, okay, that's good. So people, my name is Gustavo Pereira Correia Sami, and I'm going to briefly talk about my work. So let me share my screen. So, okay, just give me a moment. No. Okay, so I'll open my presentation. Okay, so can everybody see my screen now? Can everybody see the screen? Hello? Okay, so you can. Okay, great. So I'll share again. I'm sorry. Okay. Okay, so today I will be talking a little bit about my work. So today I'm going to be talking about the benefits of exercise and holistic therapies in the prevention and the treatment of degenerative and demyelinating diseases. Yes. So what happens is when we are talking about these diseases, exercise and holistic therapies, they can play a very important role in the prevention and also in the management of degenerative and demyelinating diseases. How? They are going to deliver a lot of important things like promoting neuroprotection, reducing inflammation, and improving overall well-being. Yes. So we do know that when we practice regular physical activity, even when we are talking about particularly aerobic and strength training, we can enhance our brain's health. We can improve motor function and potentially even delay the disease progression in conditions like, for example, multiple sclerosis and Alzheimer's disease. Yes. So all these complementary therapies like yoga and meditation, which focus on stress reduction and mindfulness, they can also contribute to symptom management and improve the quality of life. So I'm going to start here talking about affect. Okay. So this is affect. So the World Health Organization estimates that 50 million people worldwide nowadays, they are at this moment affected by neurodegenerative and demyelinating disorders, for example, like Alzheimer's, which is considered the most common form. So this number, yes, this 50 million people number that we nowadays have, it's estimated that 55 million people had dementia, for example, in 2019. And this number is projected to increase to 139 million by 2050, which is a lot. Yes. So the idea here is I'm not talking about the eradication. I'm not talking about the cure of the diseases at all. I'm talking about ways that we can do to prevent and also to treat these diseases. Yes, and here when we are talking about prevention and treatment, there are some lifestyle factors that we have to consider. And we also have to live them, to actually follow them in order for us not only to prevent, but improve the treatment of these diseases. So we have here some key factors to consider, such as having a healthy and balanced diet, taking regular physical activity, increasing mental stimulation. When we are talking about mental stimulation, we can even do here simple exercises, for example, like crossword puzzles, or all these simple activities that we know that can lead to mental stimulation. We also have quality sleep, so stress management, weight management, and here also another one that plays a paramount function here, which is early detection. Yes, when we are talking about these diseases, it is fundamental that we take regular exams so that we can detect it as early as possible. This is going to be fundamental. Why? Because we know that the advancement of these diseases, they go really fast. So if we detect them in the beginning, the most effective the treatment for this is going to be. Yes. So let's talk a little bit about the impact of exercise when we are talking about these diseases. So the first thing that we can consider is neuroprotection and regeneration. So when we are talking about exercise, aerobic exercise, strength training, this can enhance our blood flow to the brain. Yes, so we will have, as a result, the reduce of inflammation and also the promotion of something that we call neuroplasticity. So this is the brain's ability to adapt, yes, and to form new neural connections. This is fundamental when we are talking about degenerative diseases. So this is going to potentially protect against neuronal damage and also potentially slow down the progression of these diseases. Another thing very important that we have to consider is modulating microglia. What does that mean? It means that the brains, the immune cells of the brains, they involve influencing their activation state and function, which can impact in a variety of neurological conditions. So microglia, in this way, it can be modulated through a lot of different mechanisms, including pharmacological interventions, genetic manipulation, and even non-invasive techniques like the vagus nerve stimulation. So the goal here, when we talk about microglia, is to actually shift microglia towards a more beneficial phenotype, promoting what? Promoting neuroprotection and repair. After that, we have the improvement of motor and non-motor symptoms. Yes, so exercise including even physical therapy and specialized exercise programs, for example, they can improve muscle strength, balance, and coordination, which we do know that are often affected in these diseases, in the degenerative and demyelinating diseases. So this is something really vital when we are dealing with people who already have the diseases. Another very important thing here is that we have the reduce of neuroinflammation. Yes, so when we are talking here about neuroinflammation, we have this condition, yes. And if we do exercise, if we take exercise, it's going to help us in the reduce of the inflammation, yes, of neurological inflammation, yes. It's also going to help us with the symptom management. What does that mean? It means that it can help us manage symptoms like fatigue, pain, and depression, which are really very common when we are talking about the diseases. And this last factor here, which is quite important, is reduced risk of cognitive decline. So we do understand that all these, all these diseases that have that present these symptoms related to the brain, to neurons, they do end up compromising the cognitive decline. So what am I talking here is, I'm not talking about something that is going to be instantaneous. No. I'm talking about things that are going to decrease little by little. Yes. So when I'm talking about cognitive decline, I'm talking about, for example, basic knowledge that we have. For example, the use of forks and knives and things like this, even knowledge that the patient had before, and he will gradually start losing it. So the exercise is also going to impact in the reduce of this cognitive decline. So let's talk a little bit now about the benefits of holistic therapies. So when I'm talking about holistic therapies, I'm talking about activities like yoga, meditation, Tai Chi Chuan. So all these modalities, let's say, they can help a lot through different ways. So we have the first thing here is stress reduction and mindfulness. So we have here a lot of studies that suggest that all these techniques, for example, like meditation, it helps a lot reducing stress, which is a significant factor in the progression of these diseases. So they are going to promote mindfulness, they are going to improve mood and overall well-being. Another thing that they are going to help a lot with is with the symptoms relief. So, for example, what am I talking about? It can help manage the symptoms of some of these diseases like muscle spasms, pain, fatigue. So it can all help regarding these specific symptoms. We have here also the improved motor function and mobility. So what happens here in this case? When we are talking about motor function and mobility, we are talking specifically about the capability that people have to move around, and also to walk. So when we practice, for example, yoga, we have very specific asanas, which are the positions for yoga, and they are going to help us to have a better muscular structure, and this consequently is going to improve our motor function and mobility. I'm not saying that the person is going to start automatically running a marathon or anything like this. No. But what I'm talking about is it's going to improve a lot in relation to movement, in relation to motor coordination and all of that. So if we are talking about the stress reduction, symptoms relief, the improved motor function and mobility, consequently, we are going to talk about improved quality of life. Let's imagine a person who is now suffering from one of these diseases. So they had a quality of life before and after. So the idea here is, I'm not talking about getting back what has already been affected, but I'm talking about, for example, we can consider that a person who has these diseases is going to have an impairment related to movement, related to body functions, to organism, and all of that. So the target here is to improve the quality of life for this person and at the same time keep what he or she already has regarding body, regarding organism, regarding capability. And consequently, we also are going to have here improved humor and mindset through socialization. When I'm talking about socialization, generally, when we think about these holistic therapies, they are all therapies that we do in a group. So, for example, yoga, meditation, Tai Chi Chuan. So you all these activities, you are going to socialize, to meet new people, to talk to new people. So this means that you are going to be dealing with people maybe that have the same symptoms, the same diseases that you have, and this is going to improve because you will see, oh, this person or that person still can do his things or her things. And also it will help the person to see that and to improve. Oh, so this is a possibility for me as well. So we improve humor, we improve the mindset of the person, which is something really paramount when we are talking about these diseases. Now, let's talk a little bit about the relation that we have between diseases and improvement. Here, I'm going to use 3 examples. I'm going to be talking about multiple sclerosis, Alzheimer's disease, and Parkinson's disease. So let's start by multiple sclerosis. So when we are talking about this disease, exercise, including, for example, aerobic and resistance training, it is going to improve muscular strength, balance, and also to reduce the fatigue in individuals who have multiple sclerosis. So yoga and other therapies, yes, like the holistic therapies, they can also help manage these symptoms like muscle spasms and improve overall well-being. Let's talk a little bit about Alzheimer's. So regular exercise and cognitive training is very, very, very important when we are talking about Alzheimer. We do know that the advancement of Alzheimer is really, really fast. Yes, and we cannot stop it. But we can improve the situation, the overall health of the person who has developed this disease. So 2 very important things that we have to focus on Alzheimer is balance and coordination. So when you're talking about balance and coordination, imagine a person who has Alzheimer. So what is going to happen is that the brain of this person, the neurons of this person is going to deteriorate really fast. And that is going to mean that we are going to compromise the balance and the coordination of this person. So we need to exercise ways to improve here. For example, basic handcraft to improve coordination, to improve balance. Exercises that do and practice motion, simple motion exercises. For example, going up and down, doing push-ups, things like this, and also adapting this to actually the health, the real life of the person. So, for example, standing up to get a tool, sitting down on a chair, going up, trying to reach something in a cabinet. These are all simple practices that we can do to improve balance and coordination in these people. And finally, talking about Parkinson's disease. So, in Parkinson's disease, we know that we have very specific related symptoms that have to do with motor, so with movement. So we have the patient that's going to tremble a lot, a hand or a leg or something like this. So here it is very important that we do exercises also to focus on balance and coordination. Why? Because we need to improve this. And when we're talking also about Alzheimer, we also have to talk about exercises that maintain the cognitive function of the person and potentially slow down these symptoms. Yes. Actually, when we are talking in general about all these three diseases, it has a lot to do also with cognition. So it's very important that we develop cognitive activities to decrease the speed of these diseases. Yes. Now, so I would like also to talk about here specifically about a project that I developed here in Portugal. I started this project a little time ago, and the idea is what? The idea is to help people who are starting to develop these symptoms, and also as a prevention. So, if you want to know a little about the work that I develop, here is the Instagram of the project. So it's called Projeto A Melhor Idade Sempre. And it's something that I develop here in Portugal. It's something that has been very grateful for me. I get to know people. I get to talk to people. We get to do these several activities to help not only in the prevention but also in the treatment of these diseases. Yes. So basically, if you want to ask questions, I don't know.
Yes, thank you so much, Gustavo Sami, for your wonderful presentation.
Thank you very much. So, are there any questions? People would like to ask questions, to comment?
Yes, if anyone has questions to Mr. Sami, please
Yes.
ask it and ask him directly to answer your queries.
I think that's all.
Yes, Mike Sturder is asking her query regarding the dosage.
The dosage of these activities. I'm not sure I follow. The dosage of the activities, of the practice of the activities? Hi?
Okay. Any more?
Is it, I'm not sure I followed the question. Was it a question about the dosage of the exercises, of the activities? Is that it?
Yes, yes.
Okay. Okay, so what happens? When we are talking about exercise and all other activities, imagine this. Let's imagine a sane person, a person that has no disorders, no diseases at all. So we always indicate that this person take regular exercise. What am I talking when I say regular exercise? I mean, 5 times a week, for example. But now we have to consider a person that has these symptoms, that has developed these diseases. So if we have someone in a perfect health condition that has to take this 5 times a week, I'm also going to say the same, and sometimes even more. Why? When we are talking about degenerative diseases, we are talking about the degeneration of neuron cells. We are talking about the degeneration of the brain. So the more we stimulate this, so the more we stimulate these activities, the more we stimulate cognition, the more we stimulate movement, the better is going to be for these people. So I would say practicing exercises that have to do with daily routine every single day, and specific exercises, for example, meditation, yoga, even going to the gym can be a possibility. So at least 3 to 5 times a week.
Thank you, Sammy. Thank you so much. Thank you for your valuable time.
Thank you so much. It was my pleasure. If anyone wants to follow, to take a look at the project I develop, you just need to go there and take a look at the Instagram of the project.
Sure. Thank you so much.
Thank you very much. Have a nice day.
Yes, you too.
Bye-bye.
Yes, thank you so much for each and every presenter who attend the online scientific meeting of Physiotherapy Conference 2025, which is in San Francisco, California, United States of America from July 14, the physical event, and the July 15th, the virtual Zoom meeting. Thank you very much for your valuable time and efforts for our conference. Hope you all are enjoyed our conference and gain insights from your fellow professionals and colleagues. Thank you so much. We hope to see you soon on our upcoming conferences.